staff and guests to the Wednesday, January 16th Board of Health meeting. We are in the Sabin Clare Conference Room, 4300 Cherry Creek Drive South, and it is 10:03, and we're going to go ahead and get started with roll call.
All right. Brown.
Here.
Barreo. Here. Estacio. Here. Ingalls.
Here.
Hammond. Here. Pastula.
Here.
Turk. Here. Van Auken.
Here. Awesome. Okay, and Amy, once again, great job with the minutes that I saw. Anybody have any comments regarding the minutes that were sent to us? Or are we okay to adopt those by consensus? We're good? Fantastic job once again. Public comments regarding matters not on the agenda. Is anybody here to address the board on anything that we're not going to talk about today? Seeing none. Do we have anyone on the phone, Amy, that you see? No? Okay, good. And then board comments regarding matters that are not on the agenda. I know we have one for sure, but anything else before we do that? I'm sure everyone has noticed we have a new face sitting at the table. So that is the comment that I want to make. I want to welcome our new board member, Ron Engel, County Commissioner. Welcome. And if you wouldn't mind, just say a couple things about yourself to the board, and maybe I'll have a couple board members to say a few things about yourself too, just so we can get Ron a little bit oriented as to who we all are. Please.
Good morning.
Welcome.
I'm Ron Engels. I am Gilpin County Commissioner. I've held that office for about 2 years now, halfway through my first term. Was Central City Mayor and on council for the decade before that. Worked for 20 plus years for the Denver School District in IT. Made the drive down from Central City every day to downtown Denver for 16 or so years that we lived up there. And in a nutshell, that's me and my professional experience.
Fantastic. Well, welcome. I'll start. Maybe just again, each board member could just say a few things. I'm a lame duck. I'll be leaving the board here soon, so I won't go into too much detail because you won't have to deal with me much. But I will tell you this. I started my public health working for Boulder County Health Department, and we did contract work for Gilpin County. So if you see a few restaurant inspections with my name on it, it was indeed me doing those restaurant inspections. So anyway, again, welcome. And other board members, you want to just introduce yourselves and let Ron know kind of a little bit about yourself?
All right. Sean Turk. When did I start here, Deb? How long? It feels like it's been decades. I think this is my second. I'm still in my first go around, so you'll have to deal with me for a while. Let's see. Sorry. In my day job, I am a project manager for AT&T Wireless. I've done some work in assisted living facilities. I have a background in environmental policy, so focus a lot on that. I've done some nonprofit and board work for the LGBTQ community. And I am the current Board of Health representative for the Cancer, correct me if I'm wrong, Cancer Cardiovascular Pulmonary Disease Grant Review Committee. Did I get that right?
Say that 5 times.
Yeah, no kidding. So welcome. Thank you. Thank you for stepping in and filling a much needed spot. So.
Welcome, Ron. My name is Ray Estacio. It's coming up on my 4th year in my first term. I've been here a while, along with Rick. Rick's been here longer. But my day job is I'm an internal medicine doc, but do a lot of administrative work at Denver Health. I'm a director of our ambulatory QI and research, and work at the University of the Colorado Prevention Center, where we have some community health programs. Also sit on the board of directors for the American Heart Association, the Colorado chapter. And other than that, I've been in Colorado since residency, which is a number of years. Yeah, I lost.
Hi, Ron. Matt Van Auken. Let me tell you all the reasons that Rick really is lame. Just kidding, of course. He'll be sorely missed. When is that? I know. I just want to make sure. I can start being lame today. Yeah, he's a lot better chair than Tony Capella was, though. So we can talk about that. Oh, hey, Tony. We can talk about that later. So my day job is my night job is I work at Heckle's Comedy Store down this. No, I don't. My day job is that I'm the Deputy Executive Director and Chief Operations Officer for a suite of companies that serve folks with developmental disabilities and delays. We serve all of Arapahoe and Douglas County and the entire city of Aurora. So we're a community-centered board. You're probably familiar with that as being a county commissioner in your neck of the woods. We serve, we're the largest by about times 2 or 3. We serve about 8,000 people a year in case management, early intervention programs, so babies 0 to 3 with developmental disabilities and delays. And then we also have a provider side of our organization that's the largest in Colorado, and we serve folks in long-term care with developmental disabilities, so group homes, employment programs, things like that. I serve on the national board for the American Association of Intellectual and Developmental Disabilities, serve on the El Paso County Human Services Advisory Commission. I'm so glad you sent that list of things that we do out. I thought, oh my gosh, that's perfectly timed. I'll just remember what's on my list. And thank God I'm not Pat, because when you see her list, you'll literally fall over dead. Like I have no idea how you manage it all. I've been on the board now for going on 4 years or 3.5 years. I'm sure you've served on many things. I'll tell you, this is easily one of the best group of people I've ever had the pleasure of serving with. Everybody always comes prepared. The staff does a fantastic job when they present to us. It's really an absolute pleasure to serve on the board, so I hope you enjoy it.
I'm Pat Hammond from Eagle County, and I'm not half as funny as these guys. But I would echo the sentiments of what a pleasure it is and an honor it is to serve on this board for all of those terrific reasons. I'm a nurse. I started out in the Army Nurse Corps a long time ago. And I've done trauma and emergency nursing and then hospice nursing for many years. And now I've kind of gone full swing and retired, except a little special duty now and then. And I'm the Veteran Service Officer for Eagle County. So I do serve on a number of boards. I'm very interested in long-term care and assisted living for elderly. So I am the board of our brand new local retirement center in Eagle County. And I serve on the State Board of Veteran Affairs. So it's an honor to be here. And half that stuff I don't do anymore. So
oh, is that right?
You're going to take it off the list.
Okay. Good for you.
Yeah. I'm learning how to say no. Yeah. So welcome. It's great to have somebody else from the mountains.
You're on welcome. I am Evelyn Borrello. I am a faculty at both CSU and CU Denver. I am a psychologist by training, and my area of expertise is disparities, health disparities, mental health disparities, disparities in prevention, primarily cancer-related disparities in prevention, control, treatment, and survivorship. And I do a lot of community work. Have a couple of CDPHE grants, so I'm a grantee too of CDPHE. And I represent District 2, the Fort Collins, part of Greeley, Boulder, Denver, North Denver area.
So
Welcome.
You represent me too, because we're in CD2.
Oh, okay, yes.
Hi, welcome. I'm Ptsd Studies. I'm the Interim Chief Medical Officer of CDPHE, and I'm the Director of all the public health divisions who will often be presenting here. I hope to not be coming back all the time soon, because we have our new Executive Director, Jill Ryan's been appointed, so hopefully she'll be here. I'm usually her backup, or I'm the backup for whoever the Executive Director is. So I will see you from time to time, but hopefully not all the time.
We don't take that personally.
Yeah.
Okay.
Well, welcome. I'm Dan Pastula. So I'm a neurologist at the University of Colorado. I'm also an epidemiologist. I mostly do inpatient neurology, as well as I run the neuro ID infectious disease program there. But I also consult a lot with the CDC. I'm former EIS at the CDC, so I do a lot of outbreak and cluster management of things. So, and I'm one of the at-large members. So kind of similar, I think you're one as well. So kind of keeping the whole state in mind with things.
Good morning, welcome, Jen Weaver. I'm not a board member. I'm here from the Attorney General's office to offer counsel to the board as needed.
We like hearing very little from Jen, and so we try to keep it that way. So if she's quiet, things are good. Don't be stressed, Ron. So, and I don't know if you've met Amy yet. Did you get a chance to meet Amy? Yeah. Okay. And Deborah, yeah, of course you know Deborah, the wonderful Deborah that makes all this stuff happen. So one final thing before we get going with document number 1 is you'll notice that we do have an election of officers. So just if you are interested in serving, please nominate yourself or have somebody nominate you. If you're not interested in serving, also just indicate that. I have to say, consider it. It, like so many things, is so fun to do things besides just being a regular board member, because you get to see a little bit more insight into what's going on in the department. It's so wonderful to meet with Deb occasionally by phone, so it's not a ton of additional work. It just gets you a little bit more context to how the meeting's going. And so do consider it. It's a real honor to do it, and a lot of fun and a great learning experience as well. So with that, I think we're ready to go. So it looks like first up is document number 1, and it looks like it's going to be Tony and Mike, but come on up, and we're going to do Medical Marijuana Research Grant Program, their annual report. And again, introduce yourself and your department, and welcome, and good to see you, and Happy New Year.
All right. Good morning. Happy New Year. Mr. President, members of the board, great to see you. My name is Tony Capello, and the Division Director for Disease Control and Environmental Epidemiology.
My name is Mike Van Dyke. I'm the branch chief for Environmental Epidemiology, Occupational Health, and Toxicology, the longest branch name in the department. Thank you.
Good morning. I'm Elise Contreras. I'm the program manager for the Marijuana Health Monitoring and Research Program.
Did you want to say anything else?
No, I think with that, we're going to hand it over to Elise, and she is going to walk you through this. Thank you.
So good morning again. I will be presenting the annual report here on behalf of the program this morning. Dr. Ken Gershman, who was the former program manager for the Medical Marijuana Research Grant Program, retired in August. So I've worked with Ken for the past 4.5 years, doing more of the coordination for the program. So I am pretty familiar with these research grants. But going forward, we are going to have Dr. Daniel Vigil, who's sitting behind me here. Did you wait for the? Okay. He's going to be transitioning into Ken's role going forward. So he will be the providing the medical oversight as well as running the scientific advisory council and oversight of these studies going forward. So this time next year, Daniel will be presenting these updates to you.
Needs your clicker.
Put it on everybody's eye.
Okay. So I would like to begin with just a little bit of background about how this program came to be. I know we have a new board member here today. So the legislation that really got the ball rolling is back from the 2014 session, Senate Bill 14455. This is really the piece of legislation that recognized and justified the need for medical research on the potential therapeutic benefits of marijuana plus its component parts. The governor signed this in May of 2014. This legislation really directed the department to coordinate a research grant program, so hence the Medical Marijuana Research Grant Program, to oversee this process. It also allocated $9 million initially for funding of observational and clinical trials. By September of 2014, we had solicited for research proposals through RFA 1353 that was issued in September of that year. And the funding set forth in this legislation was set to expire June 30th of this year, so June 30th of 2019. So it was a 5-year time period. Fast forward to last legislative session, 2018, the legislatures granted an additional $3 million in medical marijuana research funding for new studies, and at the same time also extended the time that our program has. So our program has been extended through June of 2023, so an additional 5 years. This past June, we initiated another request for applications through RFA 10460. And if you will recall, back in November, the board approved 2 studies, one for autism, studying of autism, and then one for reduction of opioid use. So those are the 2 new approved studies. Details about those studies won't be presented today as we're still in the contract process for those, but those will be presented in annual reports going forward. Okay, so a very high-level overview of the 2014 grants. So Board of Health approved 9 grants for that $9 million between December 2014 and February of 2015. That consisted of 6 observational studies and 3 clinical trials. So there was, as of September of 2018, that is the most recent study progress updates we've received from these studies. They're supposed to send them to us quarterly. So the last Q4 of 2018 is actually due at the end of this month. So we didn't receive those in time to present to the board today. So everything, all these updates are going to be through September of 2018. So we had a total of 564 study subjects enrolled through September for the observational studies, and a total of 130 subjects enrolled for the random controlled trials. Oops. I think I missed one. There we go. And then again, just like an overview of some of the challenges some of these studies had encountered. And just to be clear, this isn't, these challenges weren't anything because of contractual mistakes or any mistakes made by the researchers. It just came to be that, this type of research is hard to do. The state, was really a pioneer in doing this type of research. And so these issues that I'm going to be explaining throughout the presentation today, I just want to make it clear that it's nothing that anyone's done wrong. It's just a difficult task in itself. So the random controlled trials, all 3 of them, did experience initial delays in the beginning, navigating through the federal requirements. Some had issues with the study drugs involved, all of which resulted in the delay of the actual study initiation. So we see that even though contracts may have been in place, actual studies didn't get started until later, ranging from October 2016 to February of 2017. Most all the studies, random controlled trials and observational studies, did experience slower than expected enrollment. A lot of them determined that their inclusion criteria may have been too stringent at first. Some went ahead and did amendments to their study protocols to improve this. Several of our studies also experienced waning interest in using medical marijuana as a treatment for the diseases in question. I'll just point out that CDPHE did try to assist these studies. Ken and I especially tried to get study flyers to be able to post on our website because we knew we had traffic coming to our websites from the medical marijuana registry. So we did try to assist on those levels. Other common issues were equipment delays, method delays in the analyses, and also several studies experienced resigning study personnel, which took time to get those replaced.
Would you remind us really quickly, was there an incentive for folks to participate?
It would depend on the study, and I can't recall off the top of my head if, yeah, some did, some didn't.
Okay.
Yeah.
Thanks.
We saw that after years 1 and 2 that the spending was under budget for all of our studies. 5 of the 6 observational studies did ask the Board of Health for a no-cost extension for year 3, which the board approved. So those are now set to expire this June 30th, 2019. And all 3 random controlled trials have an expiration date of this June as well. As we're going through these studies, I'm going to point out that some of them may have expressed interest in continuing their study, so another no-cost extension. But I want to be clear that we're not asking the board today for a no-cost extension, but rather we would like you to be thinking about if that would be plausible and if that would be something we could come and ask you at another time. Okay, so now I'm going to go through each study as their progress has been reported through September 2018. So the first study is one that has actually been completed. It's the observational study of high CBD to treat pediatric epilepsy. This was a grantee out of CU Denver. Location was at Children's Hospital. The primary aim was to determine how use of high CBD oils affects children with medically refractory epilepsy. Enrollment closed in December of 2017. They ended with a total of 21 subjects in the final analysis. Their initial target was 75. Some initial challenges they faced were that with the recruitment, their criteria required the families not to have used CBD within a certain time period. They found that was difficult to try and find people like that. So they did revise their protocol to adjust that need. Apparent decrease in interest of high CBD oils by this patient population. This was also seen in another one of our studies as well. And initially there was some issues with Children's Hospital requiring that the patients had a medical marijuana card in order to use the product on hospital grounds. However, data has been collected and analysis is in process. Abstracts have been submitted to the American Epilepsy Society and 1 to 2 manuscripts are planned.
Dr. Pastula.
Quick question. That decreased interest in the CBD oil, do you or Children's Hospital have any thoughts on why that is? Out of curiosity.
So when we talk to the researchers there, it seems like we hit this a little bit late. Like a lot of their patient population had already tried it and found it didn't benefit them and stopped using it and was no longer interested. So I think at least at the children's population, the children's patient population, and what the physicians there say is they've seen a decreased interest in using CBD. So I think that's the main problem, and I think that's the reason they finally decided we got 21, we really wanted 75, but we're just not able to recruit anymore.
Thank you.
Yeah, that's interesting because that's a finding in itself in terms of selection bias. But it'll be interesting in terms of what since they already submitted it looks like you're going to present it at the American Epilepsy Society. Have they kind of talked about the results at all then?
So one of the things we've had to be really careful about is what kind of results get submitted to us. And we really don't want the scientific data before it's published, simply because that's subject to Quora release, and that interferes with the whole publishing process. So we want to get this out as widely as possible. So in our quarterly reports, we're really looking for progress updates and telling us, and not necessarily the scientific results. We're going to get those a little later.
The next study is the observational study, quality of life in children with brain tumors. Again, the grantee was through University of Colorado, Denver, Anschutz. Study location, again, at Children's Hospital, Colorado. The primary aim here was to determine whether cannabinoid use by children with CNS tumors is associated with changes in specific symptoms such as nausea, anxiety, pain, fatigue, etc. It also had a secondary aim of determining if there was a financial impact on the families. This study had a target enrollment of 50 and is at currently 29 as of September, that is. Challenges in this study so far also include a decrease of influx of pediatric patients coming from other states for their tumors to be treated. Also, initially over-restrictive eligibility criteria. And then they ran into some subcontracting issues between the university and Children's as well. They also have plans. They were one of the no-cost extension people that got it extended through June 30th of this year, and they're completing analyses. But this is one that has expressed interest in another no-cost extension. They have said that they would like an opportunity to collect more data because they've run into some data collection issues, and that's mostly because of the patients dying before all the data points were collected. Also, some families have decided to discontinue use of the treatment as well. So they have expressed interest in extending time to hopefully get closer to 40 subjects and more data points. They have given us some preliminary findings of interest that's showing some decreased function during treatment compared to untreated samples. This is the neutrophil assessments. Yeah.
Was that just like anecdotal finding, or was it a pre-study hypothesis? I mean, because you could find things by accidents. That's why it's always.
This is a preliminary finding that was reported in their progress report to us. So again, to Mike's point, they don't share too much, but whatever they would like to share with us, they do.
And I don't think that was necessarily one of their main specific aims. It's kind of been one of those sub-aims that they looked at along the way.
So that's not only interesting, it's a little worrisome finding to me, because the neutrophils are part of the immune system. And if you have cancer, you want a good immune system and you're at risk for all of this stuff. So are they going to explore a little bit more what that is and what's causing that? Because that's a little worrisome to me.
I don't think in this particular study they're looking for that. I mean, that's really, I think, the focus of additional study moving forward, since this one is mainly focused on quality of life more than anything else. So, I mean, I think it's interesting, and, you know, lots of studies have those interesting side findings that need to be followed up later. And I think that's one of those.
Yeah, I would have to agree with that, because it's just it's a finding, and unless you had it in your hypothesis in the beginning, and that you had a conceptual model why it was happening. Because, I mean, that just opens up the question to study it further, I think. So, thank you.
And I'll also mention too, as we're getting Daniel up and running on this, he'll become more of the expert and know these protocols and hypotheses initially, so he can better answer your questions than I can at future meetings. Okay, the next study is observational study of marijuana for sleep disorders. This grantee and study location is National Jewish Health here in Denver. Their primary aim is just to identify how marijuana is currently used for sleep disorders and disturbances. The secondary aim to determine how marijuana affects sleep onset and quality. They've had really good enrollment. As of September, they were at 180 from their 182 target. Challenges that this study has encountered have been mostly data-related, data entry. They did have some equipment issues at one point where it caused a 3-week delay in their study. There's been no enrollment also for 3 months while they were recruiting and hiring a new study coordinator. So again, the retention of staff, a challenge here as well. Their plans as of September again were to continue recruiting, and they were part of the prior no-cost extension before as well, and are still set to end of June this year. Yes.
A general question for each of them, but kind of related to this. Did all of the medicine that was used for the various studies come from the same source? And was it, how did they vary the formulation of what they were using? Did they get into that a little bit in terms of what they were striving for? And did that end up being kind of a major hurdle for them, or how did that work? And I'm sure it was different for each study, Mike, but just kind of generally. It
was very different for each study. I mean, the observational trials, I mean, they were really responsible for getting their own medicine. So the study staff, the study physicians really had no say in what they were using. They just collected the data. So for example, this one would be all over the board. In terms of the RCTs, that varied some. We have some that acquired their study drug from NIDA, particularly the PTSD study. And then we had some that, I mean, we have at least one that used, off the shelf GW Pharma Epidiolex. So it did vary, and it just depended on the study design. So, and I think that continues to be a major drawback to doing marijuana research, is that we really can't use the same kind of marijuana that's available on the market in Colorado. It's just one of those issues. It's not possible to do a clinical trial that way right now through the federal process.
That's okay. Thank you. Okay, so we do have 2 PTSD studies that we funded. This is the observational study. This is the grantee was out of University of Pennsylvania, but the study location was here in Denver at the VA Medical Center. Primary aim here was to determine whether persons with PTSD will exhibit lower symptom severity, with a secondary aim to determine whether they will exhibit greater self-reported and objective psychosocial functioning. They met their target enrollment of 150 as of September. Challenges that they encountered included study start delay due to some IRB issues initially that were resolved. More challenging to recruit non-marijuana users in this group. We've heard anecdotally that there are many PTSD sufferers that use marijuana, so they did have a hard time recruiting for this study for finding non-marijuana users. They do have plans to continue. They're still kind of following up with, even though they're not actively enrolling, they're still continuing to collect data points through follow-up appointments. They are also a recipient of the no-cost extension, so they are set to end this June as well. The next study is the observational study for marijuana, for inflammatory bowel disease, IBD. This grantee is also University of Colorado, Denver. A study location, again, at Children's Hospital. Their primary aim was to determine whether marijuana use is associated with improved measures of IBD activity in adolescents and young adults, with a secondary aim of whether marijuana use is associated with changes in immune cell function. Their enrollment, it was at 131 at the end of September. They indicated they were no longer enrolling to meet their timeline of completion by June 30th of this year. They indicated challenges, including delay in some laboratory methodology concerning the T-cell analyses. Actual enrollment rate for this was at holding steady at 70% of the patients that they were recruiting at the clinics. They had anticipated higher percentage of enrollment rate, but they did receive a no-cost extension through June of this year, but they are also interested in extending the contract as well. They've expressed extra time to do more sophisticated analyses of their data. and includes some help from a biostatistician as well. They have also published one paper already, which I'll kind of go over in the next slide, and they have a second publication coming soon. So the first study that they got published was marijuana use by adolescents, young adults with IBD. This was a study that characterized their study population, and so they present results here that 32% had ever used marijuana. 9% were daily or near daily users. Again, this is a comparison of ever users to never users. Of those who completed the questionnaire, 57% indicated they were using marijuana for a medical purpose to treat pain. And 37% had experienced problematic cravings or strong urge to use as a result of using. They've concluded that this marijuana use is common among young adolescents and young adults with IBD. They perceive it as being beneficial, and they also identified a clinical need for screening, testing, and counseling in this population. The next study is the Pharmacokinetics study of high CBD oils for pediatric epilepsy. Again, the grantee was from University of Colorado, Denver, study location at Children's. Their primary aim was to describe pharmacokinetics of CBD and THC in pediatric patients with epilepsy, with a secondary aim of describing the pharmacokinetics of other anti-epileptic drugs taken in conjunction with CBD in order to evaluate drug interactions. Their enrollment as of September was 42. Again, no longer enrolling to meet the deadline of June 30th of this year. Their initial target was 60. They experienced challenges with their anticonvulsant assay, but these problems were fixed, so it didn't delay them too terribly. Initially, they were passively recruiting subjects, but learned that they needed to recruit more actively. This study was pretty intense, requiring 10 hours of clinical research in the unit with an IV. And then they also experienced the same disinterest by the study population. They're currently validating results, analyzing the pharmacokinetics, and evaluating THC concentrations in select patients. So they are still set to be done by this June. Now we get into our clinical trials. So the first one, a random clinical trial of marijuana for PTSD. So this grantee was the Multidisciplinary Association for Psychedelic Studies, MAPS, out of Santa Cruz. Their study location was ended up being just Scottsdale. They initially had partnered with Johns Hopkins, but Johns Hopkins decided to pull out of the study. So the study in its entirety was moved to the Scottsdale location. The primary aim was to compare the effects of 3 active concentrations of smoked marijuana and placebo on PTSD, symptom severity in veterans with treatment-resistant PTSD. They did meet their target of 76 as of the end of September. Their challenges included slow enrollment in the beginning, some cooperation issues from the Phoenix VA Medical Center, where they were trying to recruit their subjects. They also experienced some staffing issues. They had hard time keeping a medical director on, but they found some ways to work around that. And they have plans to complete their data, do their data analyses, that is, continue quality control checks, begin analyses, and reviewing plans to publish. This is one that has also expressed interest in in extending their contract as well. Their last subject was actually recruited on October 8th. So they would like a little bit more time in order to analyze and produce a manuscript. And they also, you know, in addition to some of these other problems listed up here, they were one of the recipients of the NIDA supplied product. They had mold issues in the beginning, which kind of delayed them. So they had some unforeseen trouble in the beginning as well.
So, and I just want to add one thing about this study. I mean, I think that we've brought this study to the board several times, and there's been a lot of hand-wringing about this study in terms of where are we going to get there? Where are they going to get the people recruited? I am actually really impressed that they were able to get their target number despite losing Hopkins as a partner. So they've done a fantastic job. And I just want to acknowledge that some of that credit needs to go to Ken, because Ken cracked the whip on this group and really made sure that they did what they were supposed to be doing. So I definitely want to acknowledge Ken and his help on this.
This was definitely a challenging one. The next RCT is marijuana versus oxycodone for chronic spine pain. This was out of UC Denver. Anshu's campus. Primary aim here is to compare effects of cannabis versus oxycodone versus placebo on chronic spine pain relief, with a secondary aim to compare effects of cannabis versus oxycodone versus placebo on experimental pain analgesia. Enrollment began again late for this study, so they actually were the latest beginning study, July of 2017. They were at a target at 32 as of September, with a target of 100, so kind of way off of their target still. Challenges: the enrollment of individuals with chronic spine pain. They have a very stringent screening criteria. They've screened over 446 people as of September, but still only have enrolled 32. They are sticking strong with their criteria. There's no talks of changing that at this point. Delay in study start due to many layers of approval from the federal government and university. And they've also experienced issues with keeping study staff as well. They have also experienced, expressed interest in a further no-cost extension for this study. They have also had issues, contamination issues with their product from NIDA that posed some further delays for them as well. They had to get a revised consent form approved by COMERB to reflect that the people might be taking a product that might be contaminated. They are still recruiting though, and as I said, expressed interest in extending their contract. So other than that, plans looking forward, intensify their recruitment, and also are continuing their IRB through the university. And as of today, their contract is set to expire this June.
So this one, I just want everybody to keep in mind, this is the first study that I'm aware of that's been approved at University of Colorado to really use inhaled marijuana to treat anything. So they've really worked hard and pioneered the strategy for getting this through the regulatory process. So unfortunately, it did take a long time, and really pointing out that they only began enrolling in 2017, July of 2017. And again, that this is a really important topic that continues to be an issue, and they really have a great clinical population and research environment to do this kind of work. I think it's just been a lot of the regulatory hurdles had never been done before.
Can I ask a quick question regarding some of those regulatory hurdles? And you mentioned them having kind of a stringent screening process. If they were to kind of adjust that, like some of the other studies have done, does that affect kind of their process with the federal approval? Do they have to go back and go through any of that, or? And I apologize for being a little naive on.
No, that's all right. In terms of the screening criteria and the eligibility criteria, it doesn't really change the federal approvals too much. The federal approvals are really around, all of the requirements about obtaining the drug, storing the drug, signing off on the drug, having a special place to use the drug. I think the eligibility issues in this particular study are really around them wanting people who haven't really used much marijuana to really be able to measure the effect better than somebody who's been a chronic user for years. So, and I think that's part of the issue, is that people who have a lot of pain, a lot of those people have tried marijuana to really address their pain issues. So I think it's trying to find that balance between a naive user and a chronic user, so you can actually measure what you want to measure in your effect in your study.
And because that's interesting to me, because the common theme with all these studies is enrollment, because I had to assume it's because they're not naive and they've tried it, because that's kind of finding in itself. Are you guys going to aggregate all these findings? And I don't know if they have like a consort diagram that just kind of tells you why people weren't enrolled, and then the lack of interest, because that'd be an interesting finding, because it kind of underestimates a negative effect or the effect on pain control or whatever topic you're looking at, because it seems like a lot of potential participants have tried marijuana already, and it's probably failed, is my assumption, and that's a finding in itself, because then it's hard to find a naive participant in these studies because so many people have tried it already. And so it'd be interesting to see, when you accumulate the enrollment, what percentage have been exposed to it so the ineffectiveness of marijuana to treat the certain conditions might be underestimated because you have a biased sample.
Yeah, I think that's a great point. I know that, we have not been working on that in particular, but one of the things that this research grant program has really developed is a fantastic consortium of researchers that really work outside the box to talk to each other and to work together. So I'll definitely bring that up next time we go to one of those consortium meetings. They think about all those challenges and what they are. And I think really putting a publication out there around those challenges would be really a benefit of this research as well.
To kind of go out what Dr. Astasio was saying. So for clinical trials or to be kind of valid in the data to be really good, the whole underlying thing is this whole idea of what they call equipoise, which is essentially you walk in there kind of not knowing or not thinking something's going to work versus not working. Essentially, well, roughly 50-50 that this is going to work or not. And the idea is that your patient population hasn't already decided that, or hasn't already kind of used it before. And I do think that is a challenge. And I do commend all the study folks and you all for kind of navigating this, because I think trying to maintain equipoise when kind of it's already been tried, even before trials, is going to be difficult sorting out that data.
No, I definitely agree. And I think even a harder thing with this particular topic is really blinding people, especially if you're doing a trial and you don't want people to know what drug they're on. I mean, it's tough to blind, especially when it's smoked marijuana and you smoke it and nothing happens. People know what happens when you use marijuana. So that's definitely another challenge to really address with these types of studies. It's different than many others. Sorry, Lisa.
We'll move on to our final study, the last random control trial of CBD for tremor and Parkinson's disease. Study location and grantee, again, were University of Colorado, Denver. Primary aim was to evaluate the safety and tolerability of CBD and Parkinson's disease. It's had 2 stages to this trial. That was stage 1. Secondary aim, stage 2, was to examine effect of CBD on severity and duration of tremor and Parkinson's disease. As of the end of September, enrollment, stage 1 was completed. They had ended up with 13. Their initial goal was 10, so they actually did better there, stage 1. Stage 2 had began, and they were at a total of 9 for a target of 75. Challenges, again, study protocol had to be revised after their measuring equipment failed, and different equipment was required for replacement. And anytime you change a study protocol, it's months delay trying to wait for it to be approved. There was unexpected elevated liver enzymes in one patient during stage 1. Those symptoms were resolved, and the patient was excluded from the study, but it took some additional time to assess the situation and implications of that. The supplier of CBD declined to provide study drug for stage 2. So Mike alluded to this earlier. This was GW Pharma, the maker of Epidiolex. And at the time, they wanted to concentrate their efforts on getting the Epidiolex approved through the FDA. So they removed themselves from stage 2, which posed an additional challenge for this study. They then had to sign an agreement with a contract with NIDA to get NIDA supplied marijuana, but then it had to be contracted to a lab to be produced into an oral fluid that could be administered. So great challenges there, but they did overcome them gracefully and were able to get stage 2 going. And I think that's really the main reason why we're seeing such slow and low enrollment numbers for stage 2 at this point in time. Let's see, the last point here. Again, with the additional federal and Irb approvals were also required for that additional step I just described. So their plans going forward, complete and submit stage 1 results for publication, continue recruitment for stage 2. Their contract is set to expire at the end of this June, but they're also very interested in the possibility of extending that through a no-cost extension. And so now we're at the end of the presentation now, but I would just like to reiterate that, we're not asking for no-cost extensions today. I'm not asking the board that, but as I mentioned, there were 5 studies that expressed interest in extending past this June 30th. All do have unspent funding. We wouldn't be asking for any additional funds. We would just be asking to carry forward the funds available. And we have checked, fiscal rule does allow for 5-year total time period contracts. So all of these do fall within that time period. And statute is clear that these funds just won't dissolve after June 30th as well. So we would like to know the board's thoughts on the possibility to extend.
And I just want to add one thing. I mean, we came and asked for no-cost extensions last February on many of these. At the time we asked for those no-cost extensions, really, we knew the legislation was set to expire in June of this year. So if we would have known that it would have been extended further, that conversation may have been a little bit different in thinking about how much time people need rather than how much time is available. So just keep that in mind as well.
Thoughts by board members? I mean, I guess I'll just start by saying I think Ken was very upfront about at the beginning of this process that this is new territory, and just navigating the regulatory and procedural pieces with universities and the federal government and dealing with the product that we're dealing with or the medicine we're dealing with would be an incredible challenge. So I'm impressed that you've overcome as much as you have. And although I won't be around for the board, just give the context of knowing the history of this, I think it makes a lot of sense to do these no cost extensions. The only thing I guess I would add is to think about starting at your stakeholder process in terms of rolling out the findings and letting some of the people that have been maybe following this from a distance kind of understand. I guess it's in some ways controlling expectations a little bit in terms of what has happened, the rate of participation, because this is a significant financial commitment that the state made. And so I think just doing that political outreach as well as stakeholder outreach would be wise. And so that when it does roll out, people are not as surprised maybe by the results. Other thoughts from board members?
I was just interested, since other states are have passed law, have you been getting a lot of phone calls or outreaches in terms of your experiences that you've thus far?
You know, on this particular issue in terms of medical marijuana research, the only other state that's really reached out to us much is Washington, who came up with some legislation to do their own research. To my knowledge, and you know, I don't follow Washington legislation as close as I could. That was kind of, there was legislation, but there was no money. The last time I heard, there was
why you're so happy, Mike.
Yeah, exactly. There's legislation, but there's no money. So I don't think anybody else has tried this besides really California being the first and doing it a very different way than Colorado, or somewhat different way than Colorado did. So I think it continues to be an interest. We get a lot more calls from states who are getting ready to legalize marijuana, and the public health department is really, what do we do sort of thing. I mean, I think that's more of a weekly occurrence.
Just give a sense about this. I know we're not taking a formal vote, but yeah.
I would just agree, especially with what Rick has said, that it's such an interest to everybody in the community. And so the more we get some information out now as to what the challenges have been, I think the results may go over better. And it would, a lot of people are very curious. I get questions about it often. And so it would help with the curiosity, and then to keep the positive interest up, to have some kind of a report, an installed report.
And I think this is really, we're starting to think about that as well. We finally have some real results, and trying to think about what that, you know, that glossy book looks like that really touts what we've done here. Because I think there really are a lot of accomplishments that we've gotten through. And one of the biggest ones is just establishing a research community in Colorado that is able to do this work, which is a huge step ahead for other states.
I think those positive outcomes will be terrific, but I agree that it also needs an installment basis to let people know what the challenges are.
Oh, no, definitely.
There's a lot of people, if you're not research minded and you're not in the field, these challenges are like, oh, really? And so I think getting that information out would be helpful.
Yeah, I know. Everybody always thinks that research takes like 2 weeks and you get results out.
Exactly.
You know, it's a long slog.
Most people have no idea of the problems of getting the medication to do the research with. That people are amazed at the issues.
Thank you.
Do it. Yeah.
So I want to reiterate that I am really impressed with you all on staff and the researchers for kind of spearheading this. Like, Colorado is kind of like the first state that's really doing this systematically, as far as I'm aware. So I think we have a really good opportunity to kind of set good quality guidelines for data kind of going forward for other states, because I think other states are going to copy what we do in Spearhead. So I do want to say thank you very much for doing this. And yeah, I think the focus on the quality of the data is going to be really important.
I was joking a little with Deborah. We should always remember, when you bring research results to scientists and doctors, it goes over schedule, but it was worth it. So thank you for your patience, and for staff's patience as we went a little longer than we were expecting. Any final thoughts from the presenters or board members before we?
We were an hour less than Ken.
I told him that too. It's a win.
And it's Michael? Daniel, sorry. Daniel, welcome, and look forward to your presentation next time, and good luck with everything going forward. Anything else before we move on to our next agenda item? All right, great. Very good. Well, thank you. And I think it looks like 2 of you will be staying, so the changeover will be easy, at least. Thank you very much. And okay, good. Daniel will join us then. And We are going to move on to document number 2, which is medical use of marijuana. And I think that's going to be Tony and Mike again and Daniel. So if you guys just reintroduce yourselves briefly for the record and tell us a little bit about this request for rulemaking.
Great. Tony Capello, Division Director for Disease Control and Environmental Epidemiology.
Mike Van Dyke, Branch Chief, Environmental Epidemiology, Occupational Health and Toxicology.
Daniel Vigil, preventive medicine physician and marijuana epidemiologist for several programs here.
And Daniel, are you in Tony's section too?
Yes.
Does he require everybody to wear striped socks, or is it just Mike and Tony?
Oh, I missed.
Don't. Sorry, Deborah made me do that. No, anyway.
Observe it, Rick.
Please, sorry for the interruption, but we'll keep you on your toes and proceed.
Okay. Mr. President, members of the board, thank you for your time. We are here to request a rulemaking hearing to update the petition and evaluation process for the addition of debilitating conditions for medical marijuana. The 2018 Sunset Review of the medical marijuana program recommended that we re-examine the process and build in some flexibility, noting that there is a lack of randomized controlled studies and well-developed observational studies as required by the current process. This current process is, quote, rigorous according to some and impossible according to others. And as the current process has not added any conditions, legislature has created an alternate pathway by designating disabling conditions and has passed bills adding PTSD and autism spectrum disorders to the, as disabling conditions.
So just for the record, entertained adding autism spectrum disorder, but has not in fact been added as of today,
right.
Just to make sure.
Yes, I was just about to clarify that that passed the General Assembly, but was vetoed by the governor. Along with that veto, he issued Executive Order 2018-004, and as part of that, he directed the department to study the use of medical marijuana for autism spectrum disorders. And if the study found no significant health or development risk, directed the department to modify the current rules to enable recommending ASD as a qualifying disabling condition. So this could not be done under the current rigorous scientific requirements. In the department's experience with PTSD and other conditions, there has often been a decent amount of evidence of potential benefit, but the lack of high quality trials or observational studies prevented approval of the condition. So there is really no ideal way to do this. We're trying to thread the needle between rigorous scientific evidence and unrestricted use while still protecting the health and safety of patients. We thought about the use of medical marijuana as being similar to experimental off-label use of medications, where there is some evidence of benefit that needs to be weighed against the potential for harm. So our goal is to allow the department and the board to consider preliminary evidence of medical benefit for proposed conditions that may not reach the level of randomized controlled trials or strong observational studies. And in addition, we tried to clarify the roles and responsibilities of the petitioner and the department. So we believe that these changes provide more opportunity for stakeholders to give input, allows the department and the board to better understand the lived experience of patients and physicians. And as a result, petitioners may have to provide more documents than previously, since more evidence would be considered. It also means that more petitions may come before the Board of Health. So under the current rule, a patient or physician can submit a petition and provide medical and scientific basis. There are not many guidelines on the particular materials that should be submitted. However, the department is required to deny the petition if there are no randomized controlled trials or well-designed observational studies showing efficacy, or if there are studies that show harm. So the difficulty of meeting these rigorous standards has been discussed extensively in light of barriers to marijuana research, including its Schedule I status. So our proposed rule would create an additional pathway for considering adding a debilitating condition that appropriately reduces the scientific rigor in order to acknowledge the barriers to marijuana research and acknowledge indicators of potential therapeutic benefit. Our rule would allow a broader scientific discussion, including the voices of more stakeholders, into the consideration of new debilitating conditions. And specifically under the proposed rule, there would be 4 categories of evidence that are needed to support a petition. The first 2 must be included with the petition. Those are documentation of therapeutic benefit in the form of published case reports, letters from Colorado physicians, and/or letters from Colorado patients. Now, the petition must include at least 2 of those 3 types. The second category of evidence is evidence of biologic plausibility. The third and fourth types of evidence, they can be included with a petition and/or gathered by the department. Those are evidence that current pharmaceutical treatments have limited effectiveness or limited acceptability due to adverse effects, and evidence that medical marijuana would be safe relative to current treatments. These 2 should include a good amount of detail about current treatments, such as typical treatment regimen, how effectiveness is measured, frequency of desired responses and of adverse effects, as well as evidence on possible harms for the proposed patient population. So the petition can include these, but won't be expected to have comprehensive evidence in these areas. The department is prepared to gather any additional evidence needed for these 2 categories. Another important update is that the proposed rule provides guidance for the board in considering a condition, specifically, quote, whether there is sufficient evidence that medical marijuana is more likely than not to provide therapeutic benefit and that benefit outweighs any anticipated harms. We did have a question about the participation of the Medical Marijuana Scientific Advisory Council in reviewing petitions. We have wanted them to have a role in the past, but the General Assembly's view has been that we could not write the SAC into the process without a rewrite of statute. So instead, interested members of the SAC have been engaged as individual stakeholders. Some things that the rule clarifies in terms of roles and responsibilities are that the department can ask a petitioner to amend a petition if the potential benefits or harms vary based on the patient group, such as age or severity of the condition. A petition cannot be submitted for an already approved debilitating condition based on symptoms for which medical marijuana is already approved, for example, severe pain. Nor a condition that has been designated as disabling by the Colorado General Assembly. A petition for a condition that has been considered within the last 3 years must include new published evidence in order to be considered. An incomplete petition or a petition lacking those required categories of evidence will be denied. And the rule allows for a condition that has been added through this petition process to be removed or qualified if new evidence changes the department or the board's analysis. So some anticipated outcomes, as I said, this may increase the burden for documentation from petitioners, but it widens the scope of the considered evidence, and some of which petitioners will have better access to than the department. And it may increase the number of petitions that come before the board. So we've identified that there are 12 conditions that are currently approved in other states that are not approved in Colorado, and it's possible that a majority of those would be submitted under new rules and come before the board. However, it's unclear whether petitions will be submitted via even a revised process or through the legislative process. Any questions so far, or should I just push all the way through?
Actually, Daniel, if you don't mind, because I want to, before we lose it too much, if Amy, if you could go to line 75. And I was struck by the presentation earlier regarding the research, and this is line 75 is where we are laying out, if you will, the standard for determining biologic plausibility, kind of the secondary pathway, if you will, or for lack of a better way to say it, maybe the more anecdotal pathway. And I guess what I'm struck by is in some of the criteria we lay out in particularly starting in kind of line 105, where we're saying you're bringing forth this evidence from people that have tried these different types of products. One thing I was struck with is that the product is so extremely variable. So when have we built into this a path? The hope would be, if we're learning that there is this medical benefit, that medical benefit is associated with a particular type of medicine versus anecdotal remarks that I'm a chronic user and I've used this for pain and it just works great for me, or it's helped my inflammatory bowel syndrome, so I just use it a lot. It's the it part that I'm wondering, are we getting at kind of understanding that or building that into the requirement? What was it that you took? When did you take it? How much of it did you take? When have you been doing it? Have you talked a lot about that? And hopefully that all made sense instead of just being alphabet soup.
Yes, absolutely. And I think there are kind of two responses to that. One is that for physician letters, we expect those to be pretty much a case report, though not yet published, and have that type of detail. Patient letters, we didn't put as much detail on what it should include, but that's certainly something to maybe take a look at, see if that one piece of being specific about what you've used with what frequency would be good. The other portion in terms of, or does that fully answer your question?
Yeah, I think okay. So. I just wanted you to maybe, again, in light of what the context of what we just heard, take another quick look through the rule and just make sure we're really mapping potential pitfalls that we've experienced in terms of the type of data that we would hope to be able to at least collect or at least highlight to people kind of what our expectations are in terms of what they're bringing to us. And Pat, maybe you want to add to that?
I have a great deal of concern about this whole thing, and I just admire how much progress you've made on it. It's a very complicated subject. But in that same area on line 116 and 117, you talk about types of intervention and administration, i.e. dosage, strength, and duration. Well, there's no standardization for dosage right now. So I'm not quite sure how you can look at the requests that come in and look at the information on dosage and strength, because it's not standardized at all.
Yeah, that's very true. And it would simply have to be the sort of the best that they could describe it. I think, you want to jump in, or I would like to add something. Go ahead. Okay. So I will make the point, though, that in our initial write, we actually talked about the type of product as potentially being part of a restriction of the approval of a condition and potentially something to amend. However, that is not compatible with the Amendment 20, which simply says, if it's a condition, then any cannabis can be used.
Along with that, in section 5, so it's line 122, it says results after a period of time of treatment. I think that should be delineated a little more carefully. Is it 1 day or 1 year or 3 months? Instead of just a time of treatment. But I'm very concerned about how we look at this in terms of dosage and strength.
Good comment. And I should actually have prefaced my comments a little bit, especially Daniel. I know Tony and Mike, you've been down this road. And this is obviously not an easy thing because we've heard pretty affirmatively that the standard that we had before with the scientific advisory panel initially in place, and then the requirement for a peer-reviewed published study for conditions under which people hadn't been able to receive the medicine in any kind of in a coherent, controlled manner. And so again, just want to, if you're hearing concern here, it's not at the work that you've done, it's more the threading the needle piece is that, are we creating a pathway that is not creating false expectations and or still having an amazing hurdle, because I think the rule kind of has both things. It's still a pretty big hurdle while still allowing another pathway. So this is a tough one. And again, just don't want you taking maybe comments from the board as being not supportive of your efforts, because I think my sense of it, again, from not really doing a survey of it, but I think that the fact that people have gone to the legislature to pursue the paths that they have indicates that there is a constituency that isn't being served by our rule. And it's trying to figure out how that becomes still a rigorous process, scientifically based, but also provides a second pathway. So again, just keep an open mind to that needle I think we're trying to thread here.
And that will not cause harm.
And will not cause harm or unrealistic expectations.
Absolutely, thank you.
Oh, so sorry, did you have, you still have some stuff left in the presentation?
Yes.
Because I can hold off until you're done, if that's okay.
Thanks.
Specific, I guess.
I'll hold off.
Okay. So
It might be a long day.
This is not a hostile board.
Okay. Well, it's really just one area of information, which is our stakeholder engagement that we wanted to share with you. I'll just read a list of individuals and entities who were invited to provide input and included in the development of these proposed rules. Colorado medical marijuana card holders, members of the Medical Marijuana Scientific Advisory Council, members of the Retail Marijuana Public Health Advisory Committee, researchers at local, national, and international universities, local public health staff, marijuana industry representatives, prevention and education professionals, Colorado chapter of the American Academy of Pediatrics, Colorado Academy of Family Physicians, Children's Hospital of Colorado, Colorado Medical Society, Colorado Psychiatric Society, Colorado Psychological Association, Smart Colorado, Autism Speaks Colorado, Strive, Northern Colorado Autism Association, Autism Society of Boulder, Boulder County, and Autism Society of Colorado. Thus far, 34 individuals and organizations have provided feedback through online survey or email. They have generally supported the expanded scope of evidence considered. Some asked that the petition process allow for more direct input from potential medical marijuana patients. In response to those comments, the proposed rule was updated to include consideration of letters from patients or parents as one line of evidence for the efficacy of medical marijuana for a proposed condition. One of those three: case reports, physician letters, patient letters. None communicated a concern that the documentation burden on petitioners was too high. The proposed changes have received support from the medical community, including a joint letter from Children's Hospital, American Academy of Physicians, Colorado Academy of Family Practice Physicians, Denver Community Health Services, Colorado chapter of the American College of Emergency Physicians, Colorado Society of Osteopathic Medicine, Colorado Psychiatric Society, and the Colorado Child and Adolescent Psychiatric Society. It was suggested that the department provide a checklist to petitioners for submitting a proper petition, and also that the department provide information on proposals that have been submitted in the previous 3 years. Department staff will incorporate those suggestions on a dedicated web page should the proposed changes be approved. I'm done.
Mike, did you want to add?
I do. Before you guys start peppering us with questions, because I know you will. We argued about this for hours. I think we wore out our whiteboard trying to come up with what this looks like. And I mean, essentially what we came down to is we were really, you always have to have that motivating example to think about, right? So our motivating example obviously was based on the executive order and thinking about treatment of symptoms for autism spectrum disorder. So as we were thinking about that, that was kind of what was in the back of our mind. And we knew a lot of the evidence around there. But I mean, I think trying to simplify this and just trying to get to where we are, where we came down, and whether or not it's right, who knows? This is a really hard issue. But we really came down to, we would like to see evidence of benefit. We would like to see evidence that that benefit is likely due to marijuana, which is the biologic plausibility piece. And then we want to feel comfortable that we're not causing additional harm. So, I mean, those are the things that we really, that kind of the common themes that every time we put criteria on the board kept sticking out. And, you know, we're scientists too. We like randomized clinical trials. We like real evidence that this is better than a placebo. But I do think we really need to acknowledge that marijuana research isn't there. And that, you know, an approved condition and a card for marijuana is a recommendation that marijuana might be effective. So it's an uncomfortable place for us as traditional scientists, but we do need to figure out a way to stand in that uncomfortable space. I mean, at least we do over here because we stand in that space every day. So hopefully that helps and really give you what we're thinking.
Great. Before, just a couple more, maybe setting the table, then we'll let the doctors jump in. And I think this is tied to the rule, but help remind the board too. A couple of years ago, several years ago, the board was presented with a rule that tried to establish caregiver patient criteria for a legitimate, I may not be using the right words, but a legitimate caregiver patient ratio. Because some of the statistics were showing that there were some docs that had quite a large number of patients and it was questionable whether there was a relationship. Have we fully resolved that criteria such that when we're getting these recommendations from physicians that we have a sense that there is a relationship there between the caregiver and the patient that is a pretty foundational relationship?
Honestly, I don't have the answer to that.
Okay, Deb, can you remind us kind of where that landed?
Right.
It's been addressed a couple times.
So taking the entire rule, because this is one piece, the petition process, we have our MMR brilliant staff here in the back. So if you start tearing your hair out, Natalie, and you need to jump in, you just feel free. So the board was presented with what is the right amount of counts for caregivers because we want this bona fide relationship. And so there is a definition in your rule. In terms of the inquiry as to the quality of that relationship, I don't want to overstate what that is, because from a medical marijuana registry vantage point, if it is coming in as paperwork that is valid on its face, it is valid on its face. So what the quality of that relationship is, we don't know. I do think it's something that we've talked about in relationship to this rule, however, because maintaining the confidentiality of the registry sort of creates a little bit of a boundary between it and the petition process. So the physicians that might be involved here may not necessarily be the same physicians that are on the medical marijuana registry patient caseload. They very well could be, but they may not be. And part of the reason why we clarified the rule the way we did is that we're also not making an assumption that all of the letters we receive will be from folks that are on our registry. It could be from retail use or other states. And so trying to be flexible about that. So before I let you jump in, does anything I say give concern here? And then Natalie, are we good? Thumbs up. Okay, we're accurate. Thank you.
Good. And I guess the other framework piece, and Natalie, again, you jump in if I misstate this, but I'm going to stretch the envelope a little here is, I guess, stepping back and thinking about the no harm piece. So we know that people have access to the recreational market. So what is it that they're getting from the medical market that they're not getting from the recreational market? And one is lower cost. We've heard that a number of times. And so that's an important component. The second piece is what we, I guess, believe to be a level of expertise that you would get at a medical facility rather than a recreational facility. I guess, I don't know if we've thought about that piece in here in terms of what the criteria is from the place that you're obtaining your medicine from, because I'm just going to speak, I'm kind of a lame duck, so I can speak a little more openly. I was quite disturbed to see some of the literature that had been coming out recently in the papers that talked about the use of medical marijuana for pregnant women to help relieve some of their symptoms. And the lack of understanding, I guess, that people were getting from that service that they're getting from the medical marijuana, is dispensary the right term I'm using there?
Sure.
So again, as we think about what this pathway is allowing somebody to do is get medical marijuana, presumably a better medicine by experts under a supervised condition. And are we getting there with the way that this rule looks right now, or is there anything else we could tweak? Again, from a broader framework perspective, and I'll let the doctors jump in. You can respond, Mike, if you want, but that more just food for thought.
I think those are all great points. And, you guys all know that my scope is very broad. But I would say that, what we're really looking at this rule as is this is really adding a condition, allowing a doctor to recommend based on that condition. What happens beyond the recommendation and where they obtain the marijuana and how that happens is really, in our view, kind of outside the scope of the criteria that we should think about. But I do think it's important to frame these criteria in the real world that we live in. And so those are things to definitely consider on your part as you think about these rules.
And just a quick for your information, that finding in particular about recommending marijuana for pregnant women was concerning to many people, including some of our partners in the marijuana industry. And there's work being done on strengthening the responsible vendor program for just that purpose.
Outstanding. Glad to hear that. And then let's open it up for people that are live this world. Dr. Estacio.
Well, I first commend you for tackling or navigating these kind of really hard waters in terms of this, because you're getting pressures from all sides. And just like you, basing a lot of my decisions on evidence-based material, I've been learning to slowly accept, it's my fourth year, accepting might be evidence versus there is evidence into my thought process. One of the concerns, obviously, that everybody's kind of voiced here is the undue consequences down the road, especially with, getting some a petition from letters from Colorado residents. And I imagine, and I'm assuming that these are just overviews or guidelines that you have here, that the process itself will be a lot more rigorous than this is pointed out here in terms of reviewing the information that you're given by the petitioner and then kind of throwing that against the clinical evidence wall and see if it sticks in that regard. So that's what I'm assuming, and I just assume that as you get more experience, you'll have more tighter guidelines as this process moves forward.
Well, I think that's absolutely correct. And we tried to balance sort of really specifying the types of evidence that were needed, the categories that we needed documentation in, with leaving the deliberative process open to weighing different things as seems appropriate for each particular petition. So we didn't want to over-define exactly what was needed to say this is an approvable condition.
So, and I think that really one of the important things to remember here is that, what this rule change really describes is that in the past, if there was not a randomized clinical trial or well-observed observational studies, we were done. It didn't come to the board. There was no further deliberation. So it's opening it up to weigh the potential harms and benefits in a more, in a broader discussion. So it doesn't just automatically cut it off, which honestly makes it a lot more onerous for the departmental recommendation. But I think that from our perspective, what we would anticipate is we would come forward to the board with information, gathered all the information, and with a well thought out recommendation of what we thought after looking at all of the evidence and these criteria.
Is there going to be a mechanism, for example, we let a indication move forward based on some petition? But is there a way that, then I assume there'll be a way to monitor the consequences of that approval for that indication?
For example?
Well, for example, if we say that there's indication for use in pregnant women, how, the potential consequences could be, humongous in terms of birth defects, et cetera. Will somebody be looking at it to say, "Oops, we made a mistake," in terms of letting this move forward, and let's retract that ruling in that regard?
So
that's what I worry about, especially some of these are kind of loose.
Yeah, and I get your concern. And, we thought about those things too. And that's why one of those things that were added was a way to, which we never had before,
right,
was a way to remove the condition. Now, does it mean that when some condition gets approved by the board, that automatically triggers some new surveillance program to look at those things? I don't think we've gone down that road. But it does mean that, as always, we're going to continue to monitor the published literature on there. And if there was a significant finding that came out in the published literature that this caused some problem, that would be a reason for us to come back to the board. And we've established a mechanism for the board to rethink their decision in light of new evidence.
I just worry because there's such paucity of ongoing studies and evaluations on this, and it's just a dearth of information. So I don't know how long we move forward or kind of blind in terms of the potential consequences. So that's, I guess that was my pitch for a potential surveillance after a ruling.
Ista, could you maybe add some context?
Sure. Just to add to what Mike and Daniel have said, I think your point is very well taken. And we don't have, for vaccines, there's an adverse reporting line. There's no adverse events reporting line for marijuana. That said, there are some surveillance mechanism in place, like for the pregnant women example. We do have a birth defects registry. We would be monitoring them that anyway. And there are different populations that we are monitoring. On the other hand, are we going to catch every adverse event? Probably not. And so that would be something that we would probably need resources for to be able to do. But it's a great point and a interesting idea.
I'm going down that same path. I'm sorry.
Yeah, when she's done. No.
Go. Yeah, Pat, go ahead.
I just,
make sure
in your write-up, you say it clarifies that for any condition added by the board can remove the condition through rulemaking. And so I was comforted by that. But to Dr. Stasio's point, that I think I'd feel better if there was actually something in the regulation that specifies how we will monitor adverse or monitor the literature or some kind of monitoring such that these issues of adverse and or harm could come to our attention.
So just so that the board understands, though, that would be a question about whether or not you want to set this for rulemaking, because to set up a surveillance program based on the concept of the parameters of the petition, to say you need to do that, we would really not want to put a requirement on staff until they had the resources there. So there are two ways I could see you going as a board. One would be knowing that that's there so that if they do bring forth a petition that meets the regulatory criteria, that's something that they could have in the mix for how it's monitored, and they could provide that as part of the recommendation. Or, board, are you saying that that's a threshold event for them to open up the rule at all and that they need to have monitoring in place? In which case, don't put this in place as a rule until they get the resources. I just want to make sure that we have that sequence correct, because I don't want to put in a rule where you as a board have an expectation that our staff can't meet because resources haven't been allocated.
I understand what you're saying, and I
don't know which way you want to go,
Yeah.
but those are your two paths that I see. And then I know Matt.
And again, maybe just a quick step back up. And Jen, I don't know if you've had a chance to look at this, but maybe weigh in a little bit too to help the board. Did you get a chance prior to this, or maybe this is a Deborah question, to, again, I think Amy's getting our lunch, but Amy, if you could maybe just go to page 3 of the basis and purpose, just so that, just remind the board kind of what, one of the reasons these guys are here today is because the Sunset Review Committee came and said, we've looked at this process and we think it's flawed. We think we understand there's issues, but we think the process is flawed. And in terms of us re-examining this process, what I find interesting is within itself, there seems to be some conflict because it says, there was an executive order and that executive order wanted to add autism that specifically requires peer-reviewed studies. But we're now trying to get a path that requires non-peer-reviewed studies. Have you had the chance to examine this at all, and kind of what pressure, for lack of a better saying, that duty we have is maybe a better word, to not only just examine this process, but act on its findings?
It's not fair. You're not.
Oh, well, if we don't act on our findings, what'll happen to us? Is that a better legal question?
Yeah, this has not come to the AG's office for our formal or informal initial review memo. I think we did do a preliminary review a while ago, but I think this has changed significantly since the last time my office looked at it.
So to the point about the discussion of being product tied in particular, we were doing some analysis for what's the authority and jurisdiction. And so when we were working on it over the summer, that's really what the angle was. So in terms of, I do think that the way Rick reframed it with, if the board doesn't do this in terms of a legal ramification, because it seems that it's really, there's a legislative pathway that can continue to be utilized. Folks may not utilize the petition process, but is there another legal outcome that you can think of?
No, I mean, I think, yeah.
Thank you. No, that's helpful, just to kind of set sideboards. Again, more, Dr. Pustula, did you want to jump in?
And Matt,
oh, Matt, I'm
yeah.
sorry. Mr. Okay.
If you want to,
Dr. Mr. Van Auken, or are you ready? Please.
Sure. I'll see your needle and raise you. So the other part of this that I think is worth mentioning from my perspective is, with all due respect to former Deputy Lieutenant Governor Lynn, the wording in the executive order is also very misleading from an overall perspective of the predominance of families that have loved ones with ASD, and how it could literally be someone who works at the Colorado Department of Public Health and Environment, has a very successful job, a girlfriend, and their own apartment, to someone who is suffering with such severe sensory perception disorders and behavioral challenges. It is literally night and day based on that spectrum that everybody seems to reference. It is my opinion that the folks who helped get the executive order through might be on one very, very far end of the spectrum versus the predominance of thousands of other folks that are on that spectrum that would not consider autism as a disorder in and of itself, let alone something to be phrased in the way with which it was. Now, that has nothing to do with you. You have no control over that. Thank you very much for allowing me the opportunity to get that off my chest. But I'm bringing that up to speak specifically to your community. What was the list you read to us? Community interaction, your stakeholder interaction. There are many other family associations and other associations besides a few that I heard at the very end that I think would be very, very interested to participate in the overall conversation regarding how things are characterized and what the real needs are. And then going back to that example that I don't think we intended on utilizing over and over again, thank you, Rick, but the whole pregnancy example. If you have a child that or even an adult with sensory perception disorder, a great many folks with autism have that disorder and not the other way around, then it might be headphones that help to drown out noise. If the headphone is the only thing that helps that individual to change what they believe is occurring in their life, that's one thing, but rarely is that the case. So there's 3 or 6 or 8 things that are put forward as a possible solution, and this, we might just be talking about one of those things, not in a vacuum. The other is there a negative implication to wearing earphones? And if there is, then what is that implication? Seems very, very different to me than, you know, the possible implications of a pregnant woman using marijuana, or a child or a young adult who begins this process of, oh, this works for my loved one. And then what are the long-term health ramifications of that? So I think there are many, many different differing opinions from family members and even associations that can speak to the overall breadth of what folks might be dealing with on the autism spectrum that didn't seem to be represented as well as I would have liked.
Well,
can I take that in?
Yeah. And actually, I kind of wanted, this is Tony Capello for the record. And so I just also wanted to touch on what Rick had said, and also I think it goes, what Mr. Van Auken has said, is kind of the purpose behind this, right? I just want to share that kind of perspective on there. And so, yeah, there was a sunshine rule, there was an executive order, and what it revealed is that for us to comply with the executive order, our current rules wouldn't allow that. So we would be in violation of that. So what this does is provide a way to, again, thread the needle, like we've said on several occasions, and find the best possible way to allow, one, for us to be compliant with the executive order, 2, to allow the stakeholder feedback that we've been getting to provide different kinds of evidence, but also hold scientific rigor. So it is a complete balancing act on that. But it also goes to the effect of allowing this additional information, as Mike eloquently said before, to come before the board. So the board still has that authority to make that decision and review every specific case, because every specific case is going to be different. But what that allows us, again, is to be compliant here and have that balance between the anecdotal and the scientific, so that we can have a better review process. And as we've already seen with what's gone on in the legislature, is that the board is being bypassed, right? And so we're hoping with this process, again, that balancing act, that we will realign where we feel these should go. They should go to the board. We have a very qualified board. We have qualified medical and scientists on this board, and it's hopefully trying to put it where it should be. And again, to Dr. Astasio's point of view, is it's not going to be perfect. We do feel we've done the best with what we're given to try to do this balancing act. And it's probably going to have to be revised, but I think it's going to align it back better to where these should probably be going, right? Is where the original intent is that we're going to open up that ability to review this a little bit better and have that. So again, it is that scientific balancing act where, you know, how do we comply with the executive order and at the same time keep that scientific rigor? But we do feel it belongs with the board. And I think that's where the board will have these petitions coming probably more frequently, obviously, would be one of the responses that we outlined in there. But again, I think that's where it belongs. So it's just another thing to keep in mind is we're going to have to be a workable process as we move forward with it.
Thank you, Dr. Capello. That's helpful. Other, oh, I'm sorry, Dr. Borreo. Did you? Yes. Dr.
So first off, again, I thank you for navigating this, because I think we're spearheading some uncharted territory here. So I am sensitive to the fact that federal laws make it really hard to study marijuana like other drugs and other medical treatments out there. But I am very wary of lowering the quality of evidence required for the Board of Health here to put kind of their medical stamp of approval on it. I don't know of any other medical treatments that we treat this way that have approvals required. Like they all require randomized controlled trials or observational studies or high quality observational studies. So this is kind of uncharted territory. And so I'm wary of that, because I think a lot of us here have taken medical oaths to do no harm. And that's my very first concern, that we're not doing some unintended harm. So I absolutely agree with kind of this whole surveillance, bringing up this whole surveillance thing, whereas as you brought up kind of your phase 4 study, which is essentially what does it do when we actually let it out in the population? So my first question is, rather than lowering the quality of evidence required for this board to put our medical stamp of approval or recommendation, why can't we just aggressively tackle the barriers to higher quality studies? So that's my first question.
I mean, that's a great question, but I think that the problem with that is that most of those barriers are federal barriers that have been, there's people attacking them from all sides, but they don't seem to be falling very quickly. So I think that's happening on its own. And I'm sensitive to what you say, and I agree with what you say. I think for me, when I started thinking about this is off-label experimental use. And you think about what the requirements are for off-label experimental use. I mean, we tried to kind of go in that direction a little bit to be thinking about the medical establishment. So I don't know if that helps for you or not, but that's kind of where we were thinking too. But it's definitely a hard issue, and we tried really hard to land in a decent place.
And I know this is really a difficult situation. I think my personal preference was, one, to try to keep attacking those before lowering the quality of evidence. Although, let's say we can't do that, and then we do need to lower the quality of evidence. One thing that I saw in here that might be helpful, that might make me personally feel a little more comfortable, in addition to maybe potentially kicking up surveillance afterwards, is, so when you talk about I think there are 3 options. There's for level of evidence. There's one, a peer-reviewed case report in an index journal. So that's a case report that a physician writes, or physicians, or a case series that they basically write like a detailed description of the case, and then write kind of their outcomes and findings, and then send it to a journal where it gets reviewed by experts who are blinded and independent, and they say, oh, wow, this is a really nice case report. Actually, this outlines well. Yeah, this should get in the literature, or this is not good at all, and either you have to revise this or change your findings. So, and I think, Daniel, as you had brought up, that option 2 is really just with the letter of physician, is really just a case report that hasn't gone through that peer review process. So I guess my question to you is, can you require option 1? Because right now what you're saying is, out of option 1, 2, and 3, you only require 2 out of the 3. And I would feel better personally requiring an independent peer review process. So essentially collapsing that option 1 and 2 into one thing. Because essentially, if you write a good letter to convince you all that this is good and should move forward, why not just throw it to a journal and let the independent peer review process happen? Because I mean, case reports aren't that hard to get published in some journal if you have high quality evidence behind it. And I think I'm just worried about leaving that independent peer review process out of this process completely. At least by that requirement, you're lowering the quality of evidence, but you still have some independent peer review process, apparently. And is that something that we can consider?
That's where we started. I mean, I think that's where we started. And that was really the first thing on our list. I mean, if you think about, quality of evidence, it goes RCTs, observational studies, and then case series, case reports. I mean, that's the way it works. So I think that's where we were when we started. But we were sensitive to the fact that we wanted to include, outside input more readily. So I think that's why we included letters from physicians. So, but I think if that makes the board feel more comfortable, I mean, that's definitely something we can consider.
If I might add, Dr. Pastula, I mean, thanks, that's helpful, and that's an interesting path, but is part of the issue the fact that are there sufficient peer reviewers out there that have knowledge in this area and that have expertise and that can do a sufficient peer review?
I think peer review is a general process. I mean, the scientific process, I mean, most people that have medical knowledge could peer review. So I think the articles are out there. The issue is it does narrow the list of conditions somewhat in that, you know, the initiating event has to be that there is a published case report. So they're out there, but it does narrow it a bit.
If we're following that up, I guess from what you're saying for option 2, that letter of physician, actually, if you look at the requirements, can we?
It looks just like a case report.
Yeah, can we pull up that?
That was on purpose.
Yeah. So it is, what line is this? Oh yeah, it'll start in line 89. So starting at line 89, it kind of outlines what needs to be in this letter from physician. And it is so detailed that it's a case report. And so all I'm saying is I would personally feel better letting this move forward if we let that referee. Because I mean, if you went to the trouble of doing this, why not go to the trouble of just submitting it to a journal and letting some independent review process happen? Because if you already done this, it's just submission to that. And granted, there are certain journals that would be more likely to do than others, but you could find a journal with some good peer-reviewed referees. And I think the other thing is, at least this way, it would force some even case reports to be in the literature, because I'm worried about bypassing contributions to the literature completely in this case, because I think we could find useful stuff here. And I think this process is, without requiring that independent peer review process, I'm a little bit worried behind that and letting this move forward. Oh, sorry.
Oh, can I follow up?
Yeah, please. Just one, again, procedural piece, I guess, just remind the board is this is a request for rulemaking, so we don't have to solve everything today. The question is there enough merits that we're hearing today to set this for rulemaking? And again, just proceed.
Well, the biggest thing, I mean, I'm fine with that, but the biggest thing that really bugged me here is scroll down to line 128, letter from Colorado residents. I mean, I feel totally uncomfortable including that on here because that's even less evidence and less, and it's like, oh my God, what does that mean? Letters, what does that look like? It's a bunch of people getting together, writing supporting letters in terms of their experience.
Well, oh, sorry.
Yeah. So that's where I was uncomfortable. Maybe you could expand on that a little bit.
Yeah, so we certainly share your concerns about these types of evidence, and I guess I would try to put it in a nutshell. This proposal is that we are proposing to expand the scope of evidence that we would look at in the process, but there is nothing that says if you check these boxes, it will be approved. That is still absolutely up to the bulk of evidence that we do see, and a very educated decision on that.
I worry increased expectations when we put this out here that there's a, like for that letter from Colorado residents, excuse my mouth being full, but
I was impressed that you took a bite. He is hungry. He missed his breakfast.
But yeah, my concern is that you can get a flurry of letters from Colorado residents in that regard, because it kind of opens that.
Amy, could you scroll down just a little further, just so that there are some criteria there too, just so it's not without content, because that's the other thing, Ray, is to, there are some trigger to those letters. They're not just go for it kind of thing. But in addition, can we get finish, and then please let's let Dr. Borrego in. She's been extremely patient. So Daniel, finish, and then if we could move to Dr. Borrego.
Just very quickly, in that category of case reports, letters from physicians and letters from patients, we would require 2 of the 3. So at a minimum, there would be some of those essentially unpublished case reports, right?
Dr. Borrego, please.
Yeah, so I think this is a time where I have to put my hat of why am I here, and what does my vote mean, and I'm not hearing the board being quite comfortable with moving this to rulemaking. And I am not, honestly, even though I don't want to be repetitive, but I really agree with everything that has been said. And that's my reaction when I started reading. Now, I do appreciate the work that you do and where you are. You are trying to, as Tony said, bring it to us, bring it to the board, create a path that it comes to the board for approval. And then, Daniel, you talk about expanding the evidence. To me, it really does feel like we're lowering the evidence. As Dr. Pastula said, you know, for everything else, we do require rigorous evidence because we don't want to do any harm. And now we have this new trend of marijuana and it's moving faster than we can keep up with. And we're legislating it and, you know, we're allowing it. And now our mandate is, you know, to consider what conditions will be considered. And what you're asking us is to expand the evidence, but to me, it really feels like to lower the evidence so that we can allow more conditions to be considered. And so this is where I'm coming from. And I really respect all the work that you have done. And I haven't done that work. But my first reaction is this just doesn't feel right. And as a board member, I am not comfortable at this point if we had to pass this to say, yes, I voted for that. And so I'm just giving you my reaction, not trying to minimize where you're at and all the work that you have done and have you engaged stakeholders. Is more, my position is to approve or disapprove with my vote. And I am, at this point, I'm not there. And even moving to rulemaking, I'm not feeling very comfortable. I don't hear anybody completely, endorsing, but that's just where I'm coming from.
Yeah.
And I'm very appreciative of the fact that we have this executive order that we've got to move on and that you've been working on it. And I think we probably could move to rulemaking. However, we've given you a lot of input and we would move to rulemaking with some of our suggestions put into it. One being, Dr. Pastula's point is very well taken, that making the peer-reviewed published study be a requirement, not one of, you had a choice of 2 out of 3, make it, that part be absolutely required, because that adds the level of medical efficacy and adds a level of scientific approach to it that I think we're all feeling is lacking. And I think maybe very clearly in the beginning saying something that providing all of this information does not assure approval, something to that effect, so that Dr. Stacio's point that people are going to expect, if they put all the time and effort into it, that it's going to get approved. This is tough stuff, and I think we need to keep the medical, scientific level. The other reason is we're going to be out there in front of the whole nation with this, and so we don't want to decrease our levels of quality control so much that we end up looking like fools because there's some harm that ends up. So I would be okay moving it to rulemaking, but we've given you a lot of stuff to put into it for us to review at that meeting.
Yep, Dr. Pastula.
Oh, is it related to that? Is it possible that, because we've given you a lot of stuff to chew on, is it possible potentially for you all to table this for now, come back with an updated proposal, and then bring it back for essentially a request for rulemaking? Or is that not a...
Yeah, I like that idea.
I think there's a couple things, and Deb will jump in here. But again, I guess just as we think about this, keep in mind the sunset requirements that were set up and the fact that people are following another pathway. And I think Dr. Capella was, I think, pretty articulate in saying, would we rather leave it up to the legislature or through a rulemaking process that ultimately has to be approved by the board without creating false expectations? So again, keeping in mind if we say no, what that means, is it better or not? Do no harm. And then I think the other thing is, I think staff has been given some direction as to where to go, but do we have another option to maybe set it for rulemaking a little further out, and then have opportunity for board to reach out to staff about specifics. There's been great feedback here today, maybe not as much direction as feedback, and maybe the board could give a bit more direction for that rulemaking, or we can choose to just not set it for rulemaking. So I think, anything else, Deborah?
The only other piece I would throw into the mix is if you're going to create a tail of a surveillance program, that needs to be part of your decision as part of the no. So setting something for rulemaking is board action. I want to make sure members are comfortable with this, because I know typically it's routine, but you certainly have that option to you. I think part of your decision making for having us not set it now and take this feedback back for staff is it does take a lot of work to do this, and more than happy to act on the recommendations that were discussed. But if they're not going to get to the level that you're actually going to be comfortable, I would rather have you just tell us now, so that we're not investing with trying to find a different rock, because I don't know if we can meet that. So I really do want you to pause before you direct us to set it for hearing or to come back with another request about whether or not we can really hit the note that you're needing to feel comfortable.
But we could table it.
You could table it, although in essence, you're basically not going to set it for hearing, and then you will come back with another request. You can direct us to do that so that I don't have it on the table. That's how I would recommend if you do decide to go that course.
Is there a concern? I haven't heard anything about proposed bills right now with the legislature. Is there an immediate urgency concern with the legislature doing something on this?
Well, there are currently 2 bills in the legislature. One is for autism spectrum disorders. The other is for any condition for which a physician might prescribe an opioid.
Wow. Okay.
So, Hello, yeah, if you could add.
Yeah, I think this is perfect timing for this. And I just want to also maybe this is a pitch, but we do have really great staff, and they're very scientifically sound. And what we would expect out of this from our part of it is that when this comes to us, we're going to do that scientific rigor. And what we're seeing now is, for example, the bills that are in front of the legislature right now is very broad. There's no rails on it. There's no guardrails, and that's how it potentially could be, and that's how this could potentially go. What we want to do is be able to do the scientific research and literature review and do all the evidence, and then provide specific recommendations. And so that could be, oh, well, we see that this age group, for example, is seeing the benefits. We're seeing this age group isn't. This type of dose is possible, this and this. So that gives the scientific rigor to run through this board that my staff will do, so that the board is more informed, and that we don't run into a process where they are bypassing the board and then anything goes. I think this gives us that chance to actually have that scientific review, that scientific backing, that review. Then our recommendations to the board are very specific, based on what we've been able to review, as opposed to a lot of this, if it goes to the legislature, is probably not going to get reviewed in a medical or scientific manner. So I just want to pitch that, throwing confidence in my staff that they will do a thorough review, and that they will make sure that it is something that we stand behind and when we have confidence in presenting to the board.
So, and, I think Ms. Hammond first, and then Dr.
So the only question right now that I'm hearing from Deb is the part about surveillance or follow through, and how we can work through that in order to come back at our next hearing for rulemaking.
Right. So for me, the question for you is, does that need to be embedded in the petition process? Or is that really a question for when you have a recommendation to add a condition about the surveillance? Going to Mr. Van Auken's point, is this a headphones moment? Or is it not a headphones moment, is going to be very much dependent upon the condition. I think which condition goes to Ptsd's point about what surveillance might be in place that's helpful to us, so that we would be able to have that. So if the board is comfortable with holding that for when there's actually a substantive decision about adding a condition, then what my ear is hearing, just to summarize, is we have feedback that says resident letters as part of the petition process is not the value add. That certainly can come in later during a rulemaking process, because you would have the opportunity to accept written testimony. So I think staff can address that. They certainly can address Dr. Pastula's point, which is combining components 1 and 2 and moving into a peer-reviewed analysis model with case studies being published. And then the third piece here is really it does not mean that you meet these things and that there isn't an analysis by the department, and making sure that there's an understanding that there's a threshold analysis that's scientific based. And if we can make those 3 changes, And I think all of those can be done if this is set for hearing in time and roll it out to stakeholders in time. And I'm getting a head shaking of yes. So I think that's the question before you. And Dr. Ghosh.
Sorry, I just to add to what Deb was saying, and to address Ray's point, I'm wondering if we had in there that in our analysis, we would examine what surveillance systems are in place existing. So whether it's poison control center calls or ER visits, or we already have an existing birth defects registry, depending on what the condition is, it might be a different thing. But if we said in there that we would review what existing surveillance mechanisms are in place, would that be useful?
Take another bite before you.
Go ahead, Dr. Stubbs.
Yes, and everything that Deb said, basically in terms of she summarized it. And when I did review this, and when I saw that letter from the governor, it was in the lens that what you said, Tony, in terms of, I don't want our Congress pushing this through and then anything goes. And it's like it, although it's uncomfortable discussions that we have here, I think they're important, but that we have more critical eye and a little bit more expertise than Congress does to let this kind of stuff push forward. So I appreciate that, because it's rough waters you're navigating again. And so the only uncomfortable thing is that letter from Colorado residents that really hits me.
So do you think, at least those changes where it's not necessarily like a formal separate surveillance program where we kind of examine what surveillance stuff is, where, essentially you're requiring the case report to go through peer review, discussing his letters, and I forgot what the fourth thing was. Was there a fourth thing that you had brought up? But do you think if we set this for rulemaking, do you think you could make those changes when it comes to? Because personally, my support for that rule would be contingent on those changes.
I think those are relatively small changes, to be honest. With the exception of the surveillance piece, and moving it towards our recommendation when we present it to the board would include what surveillance mechanisms are currently in place to allow the board to consider whether that's sufficient or not. I think we could definitely include that. But I think the additional surveillance is really dependent on resources.
And again, for context, I think the board has this. Tony, I believe you were on the board when this board voted down PTSD. And PTSD has been approved using a different definition. So a recognition of the reality that we're within here, and whether we can put sideboards on this or not, is also really important. But also, I think the board has made compelling comments about this is a board that has standards as well, and the political process is a political process, and I don't think we'd want to have to mix those. So the board's will to see if we can call the question whether we want to set this for rulemaking. We'll probably want to do a vote on that, do you think? Since I think it's gray enough, maybe just a hand vote. Is that okay? All those in favor for setting it for rulemaking, just raise your hand.
1, 2, 6, 7, 8.
Oh, it looks like we got. And those opposed? Did you went in? I thought you were gonna.
She was persuaded.
Honestly, yes. I think with those changes, Tony, I really appreciate what you're bringing to us, and really makes me think, and that's why I'm willing to move on this, is because I think you're absolutely right, and I'd rather us consider it, having an eye for, what seems to be sufficient evidence for us to approve a condition.
Thank you, Dr. Morel. Commissioner Ingalls, this is what a light lift is. So welcome. We're set, okay to set this for a rulemaking, and any volunteers for chair? Dr. Estacio, are you okay? Or you're going to want to be active? You want to be chair. I saw you move your arm.
I actually wouldn't recommend that he serve as chair.
Yes, he'll want to be engaged. Mr. Turk?
I have the least amount.
Okay. Awesome. Thank you.
Yeah.
Okay.
I'd like, only because you bring your scrutiny.
That's a great.
Yeah.
Okay.
Great suggestion.
Good.
Okay.
Welcome,
Sounds great.
Daniel.
Well, no, we
Thank
got
you.
through Duck too, everyone.
Okay, good. Well, I think I've been told that we have two things that we could potentially do. One is Milk and the other is Martha. So what is the will of the board? Milk or Martha?
I'd actually like to offer a third option.
Do you need 5 minutes?
No, well, no, I helped myself. Thank you. I was excited to see how many staff showed up for the milk conversation,
Yes.
clearly. So that's probably what we should do. But I have a conflict and would like very much to participate in the nominating process.
Oh.
And so I was wondering if we could call an audible and move that up a little bit. I have to leave at 12:45 today to do a community engagement meeting with 300 family members in Aurora.
So if staff
Can we
would,
do Martha?
yeah, if staff is okay, we appreciate your patience.
Is that okay? I'm sorry
I think
about
more, Jeff, no offense, but more for Martha than Milk. So if it's okay, and Martha, I'm setting you up hopefully for a little bit of humor here. But if it's okay, the board will discuss Martha's fantastic and dedicated service to the state of Colorado and to this department, as well as to several other commissions. And then we will take up board elections. So staff for Milk and Dane, sorry, but bear with us. And I'll turn over to Deb.
Okay. Miss Martha, can you come on up?
And let the record show she's more important than the FDA.
So I'm going to try to do this off mic. I'm a little bit fortunate because when we do staff recognition, I usually find somebody that has a particular presence for that individual. Monica Sheets could not be here today. She's out of town, but I know she's been with you for much of the duration. That was a boon for me because I really wanted this one. And so I'm really grateful for this opportunity. Really just wanting to just take a couple of minutes just to show our appreciation and gratitude. So I mentioned to Martha, it's the Board of Health. They're going to want to recognize you. And her first quip was, wait, I haven't done anything for the Board of Health. And that made me very nervous to think that just for even a moment, she could leave this department with not understanding what she has done for this board. So when I train CDPHE staff, my opening line every single time is this board cares about how you do the work as much as what the final words on the page say. And Martha epitomizes how we do this work. She is a role model to so many of us. And so for me, it is respect and in service and sincerity and gentleness, which is a word we do not use often enough with our leadership. Folks make fun of me a little bit, especially my environmental friends, because some of that's from Lao Tzu. But it's also from our core competencies, which are true for every state employee. They are a touchstone. It's one of the few things that has upheld the test of time for the state executive branch. And I know that they matter to Martha.
And Jeff, I think, I don't know, did Carrie come with you? If you could just
No, he's not
introduce.
here today. We got second
Yeah.
string with Sean.
Okay, Sean. If you could introduce yourself and please present your proposed rulemaking.
You bet. My name is Jeff Lawrence. I'm the Director of the Division of Environmental Health and Sustainability.
Sean Scott, the Deputy Director for the division. And just to be clear, standing in an uncomfortable place as it pertains to a dairy cow has a completely different meaning than the prior reference.
I appreciate being here, and thank you, Chairman Brown, for recognizing me as patient and putting that on the record, because that's typically not a phrase Martha used in any of my reviews. So I appreciate that being on the record here. We're here today to request the Board of Health schedule a rulemaking hearing to consider proposed amendment to 6 CCR 1010-4, the Colorado Milk and Dairy Products Regulations. As Chairman Brown indicated, typically our requests for rulemaking hearings and documents are presented by Carrie Rubel, our Regulation Development Coordinator, and our manager for the program for which the rule is being considered. Both of those most capable staff aren't able to be here today, and we did an exhaustive search for other capable staff and somehow came up with Sean and I. So that's why we're here today. Some background: every 2 years, Colorado's milk and dairy regulation is updated to incorporate by reference the most recent version of FDA's Pasteurized Milk Ordinance, or the PMO. The board last adopted these regulations in November of 2016, and the PMO is the official document establishing sanitation requirements that govern the nation's milk and dairy industry, and is updated at the biannual National Conference of Interstate Milk Shippers. The incorporation by reference of the 2017 PMO into Colorado regulation maintains alignment with national standards and sustains significant efficiencies in the biannual rulemaking process. In preparation for this request in October of 2018, staff notified stakeholders to discuss proposed changes to these regulations and request their feedback. Consensus on the adoption of the revision has been achieved, and multiple stakeholders have submitted their letters of support. And with that, we thank you for this opportunity to present these regulations, and we'd be happy to answer any questions or address any comments you may have.
Questions or comments for Jeff or Sean? You know, just a comment, and then we'll see if we're okay to set it for rulemaking. Just in looking at the rule, thanks to Carrie. I know he can't be here, and for staff for setting up the tour that we did to help us understand the context of these rules. That was really a highlight of my experience on the board, to understand how that works and how the rigor that goes into the production of our food and our milk, and especially since we did the word is escaping right now, the natural process. Why am I forgetting? Organics. Yeah, the process of maintaining organic standards. So again, just pass that along to Carrie. That was a and the other staff. That was a fantastic experience. Ms. Hammond.
Pass this, we'll get to go on another dairy tour.
You might get some ice cream, but
the best. I mean,
it was a lot of fun.
How often do you get to birth a calf? You know? So fun.
I did hear that occurred.
We have robots now, so not for the birthing the cows.
Yeah, Dr. Pastula.
So thank you for teaching me that there is a milk shipment conference,
yes,
and that they have voting delegates, neither of which I actually knew existed. So thanks for opening up this world and kind of teaching us. Thank you.
Good. Other than that, I think everybody's comfortable with settings for rulemaking. Pretty straightforward. It does look like it's a little more extensive than it has been in the past, so look forward to rulemaking. Jeff?
Yeah, thank you.
Good.
Who wants to chair? Sean's already tapped.
Ms. Hammond?
He raised his hand first.
Well, I could chair because I'll chair for both.
Dr.
Okay.
Pastula, great. Thank you for volunteering.
Difficult case.
Good. Yeah. Again, thank you, Sean. Thank you, Jeff. Appreciate it. Good
you.
luck with
Appreciate
everything. And we won't let Carrie know that you said he was more capable. Deb's sending the email right now. Take care, you guys. All right. And then a thanks to another person that's been extremely patient. We are going to move to document number 4, which is Regulation 4, Rules and Regulations Pertaining to Preparation for Bioterrorist Event, Pandemic, Influenza, and Outbreak by a novel and highly fatal infectious agent or biological toxin. And I think for sure. We have Dane, oh yeah, and Julian, and welcome. And again, thanks for your patience. And please tell us about your request for rulemaking.
Thank you, Mr. President. Thank you, board members. Actually, it was my own desire to come and to sit here through this today, because I've spent so little time coming to board meetings and having an opportunity to present, that I wanted to learn from everybody else what to do and what not to do, so I do know next time I need to wear the striped socks. So good afternoon. I'm Dane Matthew. I'm the director of the Office of Emergency Preparedness and Response.
And I'm Julianne Bertone, and I am the Communications and Policy Analyst for the Office of Emergency Preparedness and Response.
We're actually here today to propose the removal of Regulation 4, the preparedness preparations of, sorry, I need to put my eyes back on. I'm going to read my notes. It's getting old thing. Preparations by Emergency Regional Medical Trauma Services Advisory Councils, or RETACs, from Board of Health Rule 6 CCR 1009-5, preparations for a biological or bioterrorist event, pandemic influenza, or an outbreak of a novel, highly fatal infectious agent or biological toxin. Regulation 4 was last updated in 2007 and was not included in the OEPR 2015 rewrite of this rule, since the department wanted more time to study the role of the RETACs and our partnership with the stakeholders. The department and stakeholders since that time have agreed that Regulation 4 imposes unnecessary and unenforceable requirements that do not improve the community's ability to respond to an emergency or duplicate other efforts that are already in place. Since the regulation was written in 2007, Colorado's 11 RETACs, which are authorized by statute to provide a coordinated approach to emergency medical and trauma care and for creating regional implementation plan for the delivering of emergency medical and trauma care, have evolved to provide coordination, outreach, and educational roles, but are not themselves response agencies. As such, Regulation 4 required RETACs to maintain up-to-date contact notification lists of pre-hospital care organizations, conduct operational notification tests twice per year, and provide advice to those organizations on creating plans for a governor-declared disaster emergency that is a result of an occurrence of imminent threat of an emergency epidemic. The RETACs as an entity would not normally perform these actions or provide notifications of an event of an emergency. Therefore, it's unnecessary and ineffective to impose this requirement upon them. Community partners recognize the role of the RETACs and have other means for engaging pre-hospital care organizations for planning and in the event of an emergency. Regulation 4 can be repealed without any impact on other community partners identified in the rule. Further, the department found that the structure established in other sections of the rule is sufficient to meet the community's needs. Thus, it wasn't necessary to substitute another local entity for the RETACs. Further, the Office of Emergency Preparedness and Response is supporting community partners to accomplish many of these requirements in Regulation 4 through the hospital preparedness program's emphasis on healthcare coalitions and the allocation of grant funding to Colorado's 9 healthcare coalitions to plan for emergencies with hospitals and EMS providers. This grant effort achieves much the same outcomes while providing local communities resources to engage in planning, coordinating, and response operations, and integrates pre-hospital care organizations into their daily processes and those used during an emergency. The Office of Emergency Preparedness and Response has engaged our stakeholders and is actively seeking input on this proposed regulation removal. As mentioned previously, we've been working with the RETACs on the removal of Regulation 4 and presented at both their March 7th, 2018 and their December 5th, 2018 statewide quarterly meetings. The Office of Emergency Preparedness and Response has also reached out to our other stakeholders by providing notifications of this proposed removal to the 9 healthcare coalitions, the Colorado Hospital Association and Hospital Emergency Preparedness Coordinators, as well as the network of statewide, regional, and local public health emergency preparedness and response coordinators. Further, the department will brief the Governor's Expert Emergency Epidemic Response Committee, or GERC, on the removal at the February 14th, 2019 meeting. To date, there have been no major factual or policy issues encountered through this stakeholder process. In summary, the Office of Emergency Preparedness and Response recognizes that the RETACs should not be held responsible for conducting or contacting all pre-hospital care organizations during a governor-declared emergency, nor be responsible for helping those organizations create plans for one. The requirements in Regulation 4 are unnecessary and unenforceable and do not improve the community's ability to respond during an emergency. Therefore, I ask for your favorable consideration to remove Regulation 4. Are there any questions or comments at this time?
Questions for Dane? Just a quick one, Dane, just in the context of if there, and Deb, this may be a little bit for you too, if there are other emergency declarations. So for example, we had a flood presentation that showed how staff had responded. How's this kind of interface? Does this fit in that overall umbrella in terms of how that emergency response process works? Would this be in a subset, or just kind of for the broader context? How does that fit, or is it discrete?
Would you like to go first, or would you like me to?
Yeah, Dane, maybe that's for
you. So this is the part where I'll say what I think, and then Dane can go, yeah, no, that doesn't pan with reality. So it's a little bit kooky in terms of the rulemaking authorization here. It sits in broad Board of Health authority to promulgate these rules. Then we have reference over to our emergency epidemic in terms of the GERC that was referenced and things like that. And then we also have core local public health agency services where emergency preparedness and response are a component. For me, this rule sort of threads those, but at the same time, it doesn't bound you in terms of the ability to bring all of the statutory power into play if there were in fact an emergency. So it sets up a rubric for us to do that well, but I don't think it sets a limit. Is that fair, Dane? And do you have anything else you want to add?
I think that's a really good point. And the biggest part about this is really to try to force the partners to play together and to plan together and coordinate together. And what we found was through this rule, it wasn't achieving that objective the same way and as effective as this new process that the Assistant Secretary for Preparedness and Response is implementing nationwide through this coordinated group of healthcare coalitions, which now work at the local level to plan and coordinate the same way that they will respond in an emergency. So taking this rule that was trying to force something to happen that doesn't normally happen, it didn't make sense. So this other process makes more sense at the local level and for a response.
Thank you. That was really helpful. Other questions? Are we okay to set this for rulemaking? Outstanding. Good. Thank you. And we do have a volunteer for chair.
Pat, right?
Pat? Great. Okay, great.
Thank you very much.
No questions for Julian? Thank you, Julian and Dane. Appreciate it. And again, thanks for your patience. Sorry we ran over a little bit. We're going to try, Tony, to go very quickly through our standing reports, and sorry to keep you waiting for the last minute, but I hear you have backup just in case we run too long. So that.
Yep, they'll be done in a minute.
Dr. Ghosh, what do you think?
Hi.
What's going on in the last moments of power?
Nothing's been going on. No, it's been very quiet. No, I'm just kidding. So I'll just be very brief. Big news, as I mentioned earlier, is that Jill Ryan will be joining us, and she should be familiar to some of the board members here. She was a former vice president of the Board of Health and a former employee of CDPHE. So we're excited to have someone who really gets CDPHE and the Board of Health joining us.
And a former county commissioner.
And a former county commissioner.
She's not former yet. Not till.
Oh, right.
She's still
She's
is.
still.
Still with you. The 27th. Yeah. Wow.
Yep. So she starts soon. And so I look forward to introducing you all to her again when she comes. And I will probably see you less, but I'm sure I'll still see you. So I also want to mention we recently, just quickly, yesterday had a measles case, a confirmed measles case in a Denver County resident who traveled internationally. We've released, Denver Public Health has released media And we have released a statewide health alert to just let people know that there's various places this person went, including a spa and various urgent cares. And so, you know, just to let people know that they may have been exposed, especially if they weren't vaccinated. It's an adult. It's an adult.
Were they vaccinated?
I don't believe we know yet. I'm staring at Tony, who is. The measles case, we don't know yet the vaccination status, do we? And then I also want to mention, I think last time I mentioned that there was a Hep A outbreak among people experiencing homelessness and street drug use in El Paso and Pueblo areas. And just to update you on that, as of noon today, we have 12 confirmed outbreak-associated cases of Hep A and 1 suspect. The lab tests are pending. 2 of the confirmed cases and the suspect case have been reported since Friday, January 11th, and all are El Paso residents and are experiencing homelessness and substance abuse issues. Among all 12 and the substance use case, the majority are male. 77% are hospitalized, and there are no deaths so far. And there are local and state public health are working together to do a variety of vaccination efforts along the Front Range related to this. And Rachel's here to answer questions related to that if you have it. She just happens to be here. Perfectly timed. Those are some of the main issues that we're dealing with right now. In terms of the legislative session, it's started and it's off and running. We have everything ranging so far from medical marijuana bills and autism, which was already mentioned, to freestanding ERs and creating a regulatory system for them. A lot of these things, if they pass, would probably end up here. So we'll keep you posted.
Questions? Just a comment. Thank you for your great op-eds for vaping and really bringing that to the forefront, and wishing you great and the department great luck on that. We need all we can get. It's funny we find ourselves in this situation, but thanks for doing such a great job on it. Other questions, comments? If not, we'll see. Deb, are we anything? Jennifer, are we? Sorry, I skipped you. Anything from the Attorney General's?
Sure, quick update, just to let you know, we found out on Monday that the Colorado Supreme Court took up the John Doe's case. So they are going to hear that. That's the case where the medical marijuana doctors challenged CDPHE's referrals over to the medical board. So they're hearing 2 specific questions. One is an open meetings law question about, and the way they phrase the question going up is whether the agency, as in CDPHE itself, is a state public body subject to the open meetings law, and whether or not a referral to a physician over to the medical board is a final agency action subject to judicial review. So we won both of those issues at the Court of Appeals, but they are going to hear those cases. And I don't know if we can read too much into it. Part of it, there's several cases currently in the Supreme Court where some of the same medical marijuana doctors are challenging the subpoenas issued by the medical board. And it's so tied into this, and it's such a mess. I think they just took everything up to try to untangle it and clean it up. But so it'll be a while before we get an order, but that's where we're at. The saga continues.
Questions for Jen? Good luck. That's great.
Yeah.
Never say never, right? My goodness. Oh. Board member activities. I see nobody's mouth full. CCPD, Sean, anything to report?
No. No, they had a meeting last week, but unfortunately I was sick all week, so I didn't get to go. I know they had a couple presentations from some of the previous grantees, and so I didn't hear any uproars, so it went well. So
Great. Well, thank you. And thanks to the committee. They do such a nice job on their mailer where they kind of highlight what's going on. So just pass along my appreciation to them. They just do such a great job of engaging so many different people and providing resource information and resources. It's really great. So thanks for your continued service on that.
I hope you all heard Sean on the radio last month after our hearing on birth certificates.
I didn't even hear myself.
Y'all need to listen to CPR more often, but he was terrific and he represented us very well.
Awesome. Thank you for that as well. Ray, tobacco review. Anything? Oh, nothing for tobacco review. And Gert was, I think
Apparently we have a measles case.
Yeah. All right. Rachel, any questions? Rachel's in the audience. Okay, good. And then Deb, administrative updates.
Sure, just real quick. I did send out or Amy actually more accurately sent out the conflict of interest updates. So if you haven't sent us back your little notes about if those are current, please do so. We just want to make sure that we are helping everyone stay above board and not get crosswise. The reappointments with the governor's office, I am working with them for understanding the process. I'm secretly hoping, Evelyn and Ray, that I can get you reappointed without having you reapply. I'm trying to be efficient, but I don't know what their process is yet. For Rick, I'm still coming to terms with it a little bit. I think he and I have been processing for a while now on this because for me it will be a huge loss, but we're also working through that and we will have an opportunity to recognize him in February for all of his remarkable contributions. So we'll see if I can get through that one too.
I recommend you keep that on the download, the recognition part. And then anything else? Nope. It seemed like there was something else that you and I talked about. Well, if I come up with it in a second.
Let me look. Go ahead and go into reports, but I can make sure.
I think we're good. Yeah. We're done through everything. So yeah, if I've forgotten something we had talked about, gosh, I don't know what it was, but it's come and gone. Are we ready to proceed with document 5?
Can I ask Deb a question real quick?
Yep.
Has there been any additional request for board contact information?
No, so the constituent that I alerted you all to has not made any additional contacts that Amy or I are aware of. So we're hoping that that has settled down. Given that you haven't been sending scary emails to me, I'm assuming that the individual was unsuccessful in getting your personal contact information. So I think we're just going to let that one lie and welcome into 2019.
Happy New Year.
Any other questions for Deb? We're set. Oh, yeah, Amy.
So I had to update everybody's expense report, so if you could just make sure your address is on there.
So the mileage rate changes on a January 1 cycle. So we also want to just do everything at the same time. So hopefully you're looking at it before you sign it. That's always a good process.
Expecting a lot, Deb.
All right. We're good then. Outstanding. So we'll move on to a couple presentations we still have. This is going to be document number 5, Healthcare Associated Infections in Colorado Antibio Program. And I think I see not Tony or I don't think is that Wendy?
This is Wendy.
Oh, okay, Wendy. Great. You're gonna go with power instead of fluff?
Oh,
no, sorry, Tony. You've been getting hard. Hey, we love you. It's only no, but you're good. Do you want to come up, Tony, or are you just gonna? Okay, good. Wendy, if you want to just introduce yourself and tell us about your presentation.
Yeah, so my name is Wendy Bamberg, and I am the program manager for the Healthcare Associated Infections and Antimicrobial Resistance program, which is in the Communicable Disease branch in DSEED. So I am going to, I know it's a lot, right? So I'm going to try really hard not to use a lot of acronyms. There's a lot of kind of technical stuff in here, but I wanted to today just talk a little bit about some updates in the HAI and AR program, including the name, which we've now added antimicrobial resistance to. So there's a variety of different topics. I'm just going to go through these fairly quickly. But I wanted to bring to the board's attention all of the work that we're doing with antimicrobial resistance. We've actually added conditions over the years that has really given us a good broad understanding of what's happening with antimicrobial resistance in the state. And so the specific organisms are listed here. They include carbapenem-resistant organisms, and carbapenems are a class of antibiotics that are basically one of the last lines of defense when you're treating antimicrobial-resistant organisms. So if organisms are resistant to this class, then we get really concerned. And so those include the 3 organisms that are listed here: Acinetobacter, Enterobacteriaceae, and Pseudomonas aeruginosa. Additionally, sort of one step below that is the next bullet, which I'm going to abbreviate ESBL, E. coli and Klebsiella. We're doing some limited surveillance in Boulder County, and that's to get an idea of what that looks like in a very small subsection of the state. We're working with several other states and CDC on this effort to understand this a little bit better. The next one, vancomycin-resistant Staphylococcus aureus, it's been reportable for a very long time in Colorado, and we've never had a case. Methicillin-resistant Staph aureus is something that is fairly common, and we do track that in hospitals, and it is one of the HHS prevention goals every 5 years when they come out. Clostridium difficile is something that causes gastrointestinal infections and is a really well-known healthcare-associated infection. We've been tracking this in 2 ways. One is every single case in the Denver metro area is reported, as well as statewide in hospitals specifically. And so we have 2 methods for tracking this, and this is used in a lot of prevention efforts that we do. Candida auris, which is a new condition, so the board heard about this last year. It's a brand new fungal pathogen. We have had no cases yet in Colorado. I would emphasize the yet. I anticipate that we will see this at some point. And Candida bloodstream infections, which is something that, again, we're working on with several other states and CDC to understand these a little bit better and what the risk factors are. And then in addition, we also have various healthcare-associated infections that are more systems-based instead of pathogen-based. So for example, surgical site infections that we track, and we have the pathogen information for those organisms, and so we can look at those too to try to detect outbreaks. Sure.
You mentioned that you track cases in the Denver area. Is it just hospitals, or is it
Yeah, so in the Denver metro area, it's every single case. So community, nursing home, whatever it is, it's actually a lab reportable condition. So it's everything. Across the state, it's hospital specific. Yeah, it's a really good question. So C. diff is the highest volume thing that we track. So there's about 3,600 cases in the Denver metro area. We don't have the capacity to be able to track that statewide. And so we're able to kind of combine the 2 pieces of surveillance to do more enhanced surveillance in the Denver metro area, which includes chart reviews, which is one of the reasons why we do it in the Denver metro area, because we have the ability to go out to the hospitals and nursing homes and outpatient offices to review those charts. But statewide, among hospitals, C. diff is already reportable to CMS. And so it's no extra burden for hospitals to be able to give us that data. And it's a good marker of kind of what's going on across the state. Interestingly, in general, we don't see as much C. diff in nursing homes as you would expect. We even had a collaborative to try to reduce C. diff in nursing homes, and the nursing homes that were involved in the collaborative had barely any cases of C. diff. Now, whether that's because they're not testing, which is possible, but we don't actually see it very much. So, yeah, so it's something, yeah, and we still want outbreaks to be reported to us. So we're hoping that's another way that we can get that information too. This is not advancing. Oop, it really advanced. Huh. There's a big delay there. Oh my goodness. Yes, thank you. There we go. Okay. So the other, one of the other kind of new emerging things is exposure events from infection control breaches. So we have a whole infection prevention unit, a team of infection preventionists in the HEI program. And they have been wonderful at trying to prevent disease. So not only do we track disease, but we also prevent disease. Poor infection control practices can lead to patient exposures of a variety of different things. And one of the things that we're very concerned about is the potential for exposure to bloodborne pathogens, such as hepatitis and HIV, as well as other types of infections. Public health identification of patients at risk because of poor infection control practices can lead to public health needing to notify patients that they might be at risk of these bloodborne pathogens. And the primary purpose of that notification is usually to inform the patients what's going on, as well as recommend that they go get bloodborne pathogen testing. This is an area where DSEED works in close collaboration with Health Facilities Emergency Medical Services Division. I have a couple of highlights of that collaboration. We've been working much more closely with HFEMSD, and this is one area. So one of the examples of these types of exposure events was a sterilization failure at a Colorado hospital, which was well publicized in the news. It led to the notification of over 6,000 patients of possible risks of bloodborne pathogens, as well as surgical site infections. Another example of work that falls into this area are drug diversions by healthcare workers. So sometimes healthcare workers who may have a substance abuse issue may actually take injection medications for themselves, and that puts patients at risk, either because of syringe needle sharing or other reasons. And also it can cause issues of transmission among patients. And so in 2018, we had 9 investigations that were related to drug diversions. Additionally, we've done a lot of work improving relationships with nursing homes. This has been a huge success. So we have traditionally worked primarily with hospitals, because hospitals have infection preventionists on staff. They're sort of used to what public health does. But we've really tried to broaden out and work with nursing homes, because nursing homes may not have the infection prevention staff, but they have increasing regulations to have that expertise. So we've not only done this work with infection prevention, but also antimicrobial stewardship, which is trying to decrease inappropriate antibiotic use, which can lead to resistance. We're able to provide both infection prevention and antimicrobial stewardship assessments. So on site, we can go out and we can help them develop their programs and offer advice. It's been wonderful for us to actually make those connections. We have now great working relationships between communicable disease and the nursing homes, which is wonderful. We're able to identify and fix gaps during outbreak investigations and infection control breaches. We've also been able to do some education events with nursing homes, very large scale. Many nursing homes have come to these events, and we've been able to do them all over the state, focusing on infection prevention, antibiotic use, and antimicrobial stewardship, antibiotic resistance, and outbreaks, so providing them with education. We also very closely collaborate with Telegen, which is the quality improvement organization for Colorado, the Colorado Healthcare Association, and the Colorado Hospital Association, and we meet with them on at least a monthly basis, and recently it's been more like on a weekly basis. So we're collaborating all together the work that we do, which has been wonderful, and again with Health Facilities EMS division as well. I'm afraid, oh, there we go. Okay. There's a big delay, so sorry if I advance it too much. So I wanted to give one example of a recent outbreak that we investigated, and this was group-based strep in nursing homes. So what we noticed over the years as we've increased surveillance in nursing homes and been working with nursing homes more, we've been able to identify more cases of group-based strep that are associated with nursing homes. And what you see here is in 2017 and 2018, we noticed a big increase in these cases. Part of this might have been somewhat due to increased surveillance, meaning that we are able to identify some of these group-based strep cases are actually affiliated with a nursing home or associated with a nursing home. But part of this was really a true increase. And so we wanted to figure out what was going on with this. And we were able to partner with the programs within DSEED in order to make this happen. So the increase in cases was detected as a result of this enhanced collaboration between programs in the communicable disease branch. What we found out was this wasn't due to one outbreak in one nursing home, but rather small number of cases among many facilities. And through testing at CDC, we were able to figure out then a lot of these organisms were genetically related. So there was something going on among these cases, something that either was something spilling over from the community or some sort of transmission happening among the nursing homes. These were primarily in the Denver metropolitan area because that's where group-based strep surveillance for invasive group-based strep really occurs. So our infection prevention team and epidemiology staff visited all the nursing homes with more than one case, or if we had one case and there were other infection prevention concerns, we visited those nursing homes. We also invited CDC to come out to Colorado to collaborate in the investigation. And this is called an EpiAid. And the EpiAid, the purpose was to identify factors that might have contributed to this and focus on why there might have been transmission among the facilities. Health facilities also participated in the EpiAid, so another example of collaboration between the two divisions. CDC infection prevention staff commented at the end of the EpiAid that they noted the close relationship between CDPHE and the nursing homes, and that was wonderful to hear. So we thought we were doing a great job reaching out to nursing homes, and CDC said that we were doing pretty well with that compared to other states. So we were pretty proud of that. I don't have any results of this investigation; it's still being worked on. And then the last topic is the Colorado antibiogram. And I wanted to just acknowledge Chris Chaya, who's here as well with me. He is the medical epidemiologist that's been working on this Colorado antibiogram. So first I wanted to explain what an antibiogram is. So it's typically used within a healthcare facility. It uses data from the facility laboratory and it compiles information about bacteria cultured from patients and among certain organisms, what is the percent resistant to certain types of antibiotics? And so a physician within a healthcare facility can use this to say, okay, I've ordered this culture, the culture takes several days, but in the meantime, what antibiotic should I put the patient on? And they can, based on what the infection type is, they can surmise what the most likely organisms are, and then look at this antibiogram to say, well, oh wow, this organism looks like it's really resistant to that antibiotic, so I'm not going to pick that one, even though I might in another healthcare facility. I don't want to do that in this healthcare facility. And so they can use that facility antibiogram. That's what it's typically used for. It's also used to inform programs designed to improve antibiotic use. So if you have a high level of resistance with a particular antibiotic, you may want to switch that off of your formulary, for example, or encourage physicians to use a different antibiotic. And that's what it's usually used for in a healthcare facility setting. The idea is that you have better use of antibiotics to both improve patient care, but also prevent emergence of resistant bacteria. So what we did with the Colorado antibiogram, these antibiograms are typically within hospital setting. Hospitals have the labs, hospitals have the staff to be able to do this, but there are these big gaps in nursing home settings, outpatient settings, in the community in general, as well as some hospitals don't have the capacity to do this. And so we wanted to be able to compile all of this data together from the facilities that do this work. Laboratories serving both hospitals and nursing homes voluntarily submitted data. They submitted their antibiogram so that we could include them in the report. So it's not comprehensive for the entire state because it was done on a volunteer basis, but we did get really good response. The purpose was to be a publicly available tool to help clinicians and facilities to improve their antibiotic use. It's less for clinical purposes because it's hard to generalize, but it's more for helping facilities develop their antimicrobial stewardship programs and use antibiotics better. It also allows us in public health to better understand antimicrobial resistance patterns. So it's almost like an additional surveillance technique that we have with this data. So this is what it looks like. So these are the organisms in the first column here. And an additional component that we captured was the number of isolates that were tested. And so, for example, in the top line for E. coli, the median number of isolates tested was about 42,000, and it ranged between 5,900 and 57,000 by facility. So that gives us an idea of how many isolates are being tested. So if you look down at Enterobacter aerogenes, which is the fourth one up, there's only 527 for the median isolates tested. So we have to take that with a little bit more of a grain of salt than the ones that we have lots of isolates for. And then across the top are the different types of antibiotics. And this main box here is the percent susceptible. So if you have, and I'll go to the next one here. So this is the hospital antibiogram example. Uh-oh, I pushed it twice. Hopefully it won't advance more. Okay, so the E. coli is at the top here. And if you go across and you look at ciprofloxacin and levofloxacin, this is Cipro and Levaquin. If you've heard of those antibiotics, that's what those are. And if you notice here for hospitals across the state, the percent susceptibility is in the 80s, which is not that great. That means that there's some resistance to these commonly used fluoroquinolones out there, and it may indicate an opportunity to use this information to target fluoroquinolones for antimicrobial stewardship purposes and help improve that use. So note these are in the 80s. So now when we go to the nursing home example, and the data for nursing homes is a little bit more limited, but you notice that the percent susceptible is in the 60s. So this is interesting. This gives us information. We didn't know what it was going to look like, and this gives us information that maybe there may be more issues with fluoroquinolone use in the nursing home setting, and can help provide additional information for nursing homes to be able to use this information. Maybe they need to target, maybe they're using too many fluoroquinolones and need to target that, and can also help us guide nursing homes and where they need to target their efforts also. So healthcare providers, in conclusion, can use the Colorado antibiogram to identify opportunities to improve antibiotic use in hospitals and nursing homes. And we, as public health practitioners, can use this to help guide and educate those healthcare providers about antibiotic resistance and what to do with their antimicrobial stewardship programs and antibiotic use. So I'm happy to take any other questions you have on any of those other topics.
Dr. Pastula.
First, I want to say thank you and your colleagues for all this work. I love this. This is great. And I think this is underappreciated at times, how potentially dangerous antibacterial resistant or antibiotic resistant bacteria are. And so by maintaining the stewardship, whereas like every time I have a friend who's like, oh, I have a cold, can I get a Z-Pack? I'm like, you know, so maintaining that so that when we do have serious infections that are antibiotics still work, and then by targeting them, and especially in nursing homes, where the resistance is, there might be more resistance to some of these organisms, and then maybe kind of peeling back to what is absolutely, you know, is needed, that, you know, we can save these for when we have serious infection. Like, that work is so important. So thank you and your colleagues for doing that.
Yeah, kudos goes to Chris for putting the antibiogram together.
Quick question. Do you notice like a big difference in resistance patterns from like different areas of the state? Like, for instance, like the Western Slope versus the Front Range versus the Plains?
Yeah, so the Colorado antibiogram, we actually did divide it into regions, and I might ask Chris to come up for that piece of it, if you don't mind to comment on that. As far as some of the surveillance projects that we do with this, there's definitely a trend that we see unique resistance patterns in the Denver metro area first. There's no question. We see more carbapenemase producing CRE, by the way, and I'm sorry for the acronyms, and I'm having to explain what that means. But basically, those are the ones that we're really, really worried about. And we see more of those in the Denver metro area than we do in other parts of the state. So we tend to see things more in the Denver metro area first. And this is for pathogens that we're actually doing full state surveillance on. We also have additional pathogens that we're looking in the Denver metro area only, and I'm not sure that we know that they're not out there, but the general overall pattern is that metro area sees it first.
Hey, Chris, welcome. What section are you, what's your title again?
Yeah. Oh, sorry. So my name is Chris Chaya. I am a physician in the Healthcare Associated Infections Program. My position is called Antimicrobial Stewardship Medical Epidemiologist.
Awesome. You get that on a business card?
Yeah, it's hard. Name tag is long. So the question was about the antibiogram and about regional differences. And so I think we did put this together by region. So we have, it's all on the website, but there's an antibiogram for the state of Colorado, for the Western region, Northeast, Southeast, and Denver metro area, and a few key large counties for the hospitals. For the nursing homes, we didn't have enough data to do that. There's so much information on there. I don't think we've detected all the differences that might be there. When I've looked at this a few times, I haven't noticed very large regional differences between the antibiograms. We're in the process of doing a follow-up one this year. And I think with a little bit of experience, we might be able to better understand that. But no glaring differences in looking at it in this particular fashion. And the other thing is we didn't do this in a statistical way where we can actually test the differences. So everything's really based on if you see something, it may be true or it may be a sampling error too.
Yeah, Dr. Stasio. Oh, go ahead, Pat.
Oh, I'm sorry.
No, you go.
I want to thank you also for the amount of work you're doing on this. It's it's a very, very important subject. And sometimes I feel like the nursing homes out in the hinterlands, in the Western Slope and way up in the Northeast, just don't get the review and the regulation that they should. And just being in a lot of the nursing homes on the Western Slope, I think the infection rate is more than you might think. And so I would love to see if the resources are available to do more surveillance out there.
Yeah, and thank you for that comment. And I appreciate the feedback that you've been seeing C. diff on the Western Slope, and that's really helpful information for us to have. I definitely want to emphasize that we're trying really hard to make sure that we're targeting those folks. And there's a couple ways we're doing that. One are these education events that I mentioned. We've done them on the Western Slope. We've done them in the Northeast and in the southern part of the state. Because we're very aware that those are folks that need additional support. Additionally, we actually have a small amount of funding that we're giving to 4 county health departments right now in order to get counties involved with healthcare-associated infections. And those are Weld, Northeast, San Juan Basin, and Boulder County. And it was open to all counties in the state. But that has been super helpful too, because then we're able to have the counties work with their own local health departments in order to kind of expand this work. And we're certainly willing to go out. We have one infection preventionist who goes all over the state to try to target those, because we realize that those are definitely areas in need. So thank you for that.
Mesa County and Garfield County have a lot of nursing homes, and each one of them is like a cruise ship. One person gets sick and pretty soon the whole place is down. So
right. Thank you.
Thank you very much.
Yeah, thanks.
Dr. Stasio?
Asking, do you participate with organizations for antibiotic stewardship projects and programs? Because I know at Denver Health, Tim Jenkins, at one point we wanted to show shame in terms of the providers, how often they. One of the things they actually worked in terms of showing how many people give antibiotics for viral URI, and so it's hard to see your name on there as one of the offenders. Not that I was. So, but do you coordinate with other, like in rural Colorado and stuff like that? Do you coordinate those kind of projects with them?
Yeah, so I'll let Chris comment on this a little bit more. Maybe the AAP project might be a good place to talk about and work with other providers.
Yeah, so there's actually a lot of different ways that we work with organizations, and the American Academy of Pediatrics one is just the latest one. But when I first started, we had a collaborative of 27 hospitals that we were part of the steering committee for. We're working on antibiotic stewardship. We work with our partners that Wendy mentioned to work with nursing homes and hospitals on antibiotic stewardship and infection control. So we're just starting a second collaborative focusing on those topics with, I think, 25 or 28 nursing homes from around the state. So it's a webinar based, so it's all of them. I go out and visit with hospitals and nursing homes and guide them on their antibiotic stewardship practices, trying to help them set up and develop their antibiotic stewardship programs within the hospitals. And then the latest thing is the American Academy of Pediatrics is working with the Colorado chapter of the American Academy of Pediatrics to do a 6-month collaborative to improve antibiotic use in the outpatient setting in pediatric clinics. And so I'm on their steering or their planning committee and providing some education input to that.
Other questions? Awesome. Thank you.
Great, thank you.
Yeah, really awesome. Chris, nice to meet you.
Thank you. It was nice to meet you.
And Wendy, great job. I think we are to the final step of the day. And I think it looks like Jennifer is going to come up. Jennifer, you know, this is, I think, I only got one more meeting. And if I'm remembering right, you come from Atlanta?
Close, North Carolina.
Okay, North Carolina. So one of my favorite, so one of my favorite presenters, because I spent time working in the Georgia area, and I kind of miss the Southern accent. So just go hard with it.
Okay. Okay.
I've been doing all this work on microaggressions. Did that? Are we okay?
You're good. I don't mind when people comment on my accent as long as they don't call me stupid.
I'm completely serious. So thank you. I do miss it. I miss working with a lot of people down there. So no aggression intended.
Totally okay. All right, so for those of you I haven't met yet, I'm Jennifer, and I am the public health veterinarian for Colorado, and I oversee the program that is very focused on animal-borne diseases, which is why you see a slide with all kinds of animals and bugs on the slide. I'm just going to give you a quick overview of what happened in 2018 in terms of our reportable conditions. On the slide are all the reportable conditions that fall within my program. There's a 5-year average, 2013 to 2017, and there's a couple of places where you'll see dashes. Those dashes are because those specific conditions were not reportable for the entire 5-year period. 2 of them became reportable in 2015, and then Zika in 2017. So the reason they're dashes is because it's not equitable. And then 2018, that's all of the numbers for the 2018 year. And everything is what I would consider fairly average for any given year, except for rabies. That everything else was kind of what we would expected. The dengue number for 9 looks kind of high, but that's actually very comparable to the 2 previous years. So once we start being able to do 5-year averages, you can see that that's probably about what we would expect. So I'm just going to talk a little bit about rabies and a couple of other ones. So rabies is a viral infection that's very unique in that it affects the central nervous system. The reservoir species here in the United States are wildlife species. The U.S. was able to eradicate the canine virus quite a while back, and we do get periodic introductions from other parts of the world where it is still very much a problem. But here in Colorado, our two concerning species are various species of bats and then the striped skunk. Infection is spread by bite wounds and then very rarely in other ways where saliva or neurological tissue could infect a wound. It is pretty much 100% fatal. There's really only one good successful survivor in the literature. The 2018 year, this is, you can see from the slide that we did have positive animals every single month of the year. We've been very fortunate, and then the last recorded human case in Colorado was 1931. We would like to keep it that way. So we keep track of the animals, and then we follow up with people and pets to try and prevent further infections. So there were, it's actually 325. The slides were made before our final case count. So we did have 325, and those 325 positive animals exposed a total of 115 people, 350 domestic pets, cats and dogs, and then 114 livestock. And the livestock numbers are kind of unique in that, one skunk inside a pasture of, 90 sheep would be 90 exposures because we don't necessarily know which ones it contacted it and which ones it didn't. So how does this compare to previous years? And unfortunately, it's really kind of bad. The previous 5 years are on the slide, and you can see, I mean, it is something that we deal with, it's out there, but last March, it actually, we had the rabies virus entered the Denver proper area in the fall of 2017, and then went into some skunk dens, and then the skunks started emerging in March, mating season, and we ended up with 82 in the month of March, predominantly from Denver, but then we ended up seeing a reemergence in Colorado Springs. So we had two metro areas that did skew our numbers significantly. The numbers rapidly drop off in April. In the month of March, we were actually doing some surveillance to try to improve the establishment. We did have some pushback where some individuals didn't think we had it in metro areas. So we were doing some surveillance animals that did not expose people or pets. We had to stop doing that on April 1st because it was basically destroying the budget for our rabies testing. So April 1st, we went back to public health only testing. And then you can see it does remain high until July, and then drops off to more expected numbers in August. So from this slide, this shows the species groupings. The blue at the bottom are various species of bats, and you can see that that number does fluctuate but is consistent. We do have between 60 and 100 bats that test positive. We never do surveillance of bats. These are all animals that have exposed a human or a domestic pet. The next color up, it looks kind of orangish. Those are the skunks. So you can see that the striped skunks were very much where our numbers were coming from this year. And on the very top is lighter orange color, 9 domestic animals, which I'll talk about in just a couple of slides. Our rabies positive animals, this is a graph of the state. The striped skunks isolate is pretty much on the eastern side of the mountains. We did, starting in 2017, start to see some spillover of bat variant into skunks. We had 3 skunks in Durango, 2 in Bayfield, and 1 in Pagosa Springs. All 6 of those animals were variant typed as bat variant, so the skunk variant has not crossed the mountains at this point. And then what's really concerning is that in the past 10 years, we've had 34 domestic animals that have come down with rabies. 25% of those animals were from last year alone. So even though rabies is not new and we've continued to encourage people to appropriately vaccinate their animals, last year was a big year with 9 positive animals, 6 cats, 2 dogs, and 1 alpaca. And so, yeah, this just represents last year alone. And then when we did have the skunks that showed up in Durango, we started querying the other states around us to see what their rabies situation was, to see if we could potentially be having some spillover situation before those animals could get variant tested. And what you're seeing on the slide is the green areas are the South Central skunk variant, which is what we have here in this state. It also exists down in southern Arizona and a little bit in New Mexico. And then the pink color is the Arizona gray fox, which is has not made its way into Colorado. And then with that, we actually did a little bit of modeling risk. We looked at where skunks are at, where rabies is at, and where we could potentially have some risk areas. And the reason I'm showing you this is because it is interesting. We did this modeling based on 2017 data alone, and where we ended up with the 2018 spillover bat variant into skunks is right in the highlighted area of the southwestern Colorado. So the next disease I want to highlight is West Nile virus, because that is in terms of numbers, that's where we see the most zoonotics in North Carolina. Oops, here we go, jumping back home. In Colorado, you started. West Nile virus, it came to the U.S. in 1999. It was not in our country before that. And then it's made its way west and entered Colorado in 2002. It is transmitted by mosquitoes. Humans and horses are what we call dead-end hosts, meaning that we don't contribute to the the viremia. We're not putting it back into the environment. The reservoirs for that are passerine birds. So any of your perching birds, songbirds, they're the ones that are moving it, which is why it moved across the country so quickly. Most humans that get it don't have any symptoms. About 20% will get some symptoms, and then a small percentage of those individuals will have neurological illness that could result in death. We've seen it pretty widespread in Colorado, but we do have some what we would consider hotspots, and that would be Larimer, Weld counties, and then Mesa counties is where we see the most human illness. And this slide represents the 2018 data. The orange line is our mosquito surveillance. We start doing mosquito surveillance sometime around the middle to the end of June, where local health departments will start trapping mosquitoes. They trap the mosquitoes and they send them to our lab for testing. And then we start tracking that. And then we stop testing sometime around the end of August, beginning of September, because at that point we usually have pretty good wide distribution and more data isn't necessarily useful at that point. But early season, we like to see what's happening in the mosquito population before humans start getting sick so that we can start recommending some control measures be put in place, such as adulticiding, killing mosquitoes before they can actually start transmitting the disease to people. The blue lines are the human cases, and that correlates the cases we started seeing them at the end of July. Our 2018 year, we actually had a very late start to the season. We started seeing it in mosquitoes later than we normally do, and then our first human cases were later than they normally were. And with that, we ended up seeing our case numbers were much lower than what they have been. There was only 96 last year. Our 5-year average has been 150. 96 is not a great number, but we can actually explain why it was lower, and that has to do with the fact that it started later. So by the time the people started getting sick, we didn't have as long of a season. And this slide, and this just shows you our very first human case was July 15th, but you can see the spike in mosquito illness did occur before that happened. And then the immediate drop there on September 9th, there was no more mosquito testing done at that point. We would have expected the mosquitoes, once they're positive, they stay positive till they die. So there was no need to do additional testing at that point because the temperatures were getting lower at higher elevations at that point. And unfortunately, we did have 4 individuals that died from West Nile virus last year. From the age groups, we rarely see it in minors, but we do see it in all adult age groups. The most heavily impacted are those between 60 and 80, but we do see it in younger age groups, and one of the deaths was actually someone in their 40s. And this slide represents the case count per 100,000. So the darker states are the ones, maybe they don't have the highest number of cases, but they may have a smaller population. And we consistently are among the higher states in terms of what percentage of our population gets West Nile virus. And then I want to talk a little bit about vector surveillance. This is a question that's come up quite a bit lately. And we did, about 5 years ago, we actually started to look to do some presence. We did a study with basically Colorado veterinarians, a voluntary submission. In 2014, at the end of the year, we sent out postcards to every licensed veterinarian in the state requesting that they send us ticks. So our data is slightly skewed in that this was completely voluntary, and it'll be skewed to the areas where there are veterinary clinicians that are seeing patients, and also veterinarians that would have been interested in this project. There was no compensation. It would have been up to them to voluntarily do it and then to pay shipping costs to get us their ticks. But we did get pretty good representation from around the state. During the 3 years of the project, we got almost 700 ticks from voluntary submission. So yes, we do have ticks in Colorado, which was something that, came up a lot. Like I heard it a lot. We don't have ticks or fleas in Colorado. Yes, we do. There may not be as obvious, but they're definitely out there. And then we analyzed the ticks that we got and did mapping for the ones that are medically important. There's a lot of ticks out there. We specifically targeted the ticks that are known to to bite humans and then transmit pathogens. So that's really what we were looking for. The first one is the Rocky Mountain wood tick. This is a high altitude tick. And you can see we got it from these locations. And we did ask if the animal had traveled. So if the animal had traveled recently to another state, those ticks were not counted in our mapping process. We still looked at them, but we were specifically looking for the animals that had not traveled out of state so that we know for sure they picked them up here in Colorado. So that's the areas where we found the Dermacentor andersonii, and then Dermacentor variabilis, which is the American dog tick, which is pretty prevalent countrywide. We can see we have that one. And then what was surprising is the brown dog tick. National maps say that it is present, but until we did this project, there had not been any positive identification within Colorado. But we did find it up and down the Front Range and then on the western slope, specifically from Cortez. We got several specimens from Cortez. But the dog parks, a lot of the dogs that had gotten the brown dog tick along the Front Range had actually been to dog parks and we believe had picked them up there. And then the last one is the Lone Star tick. This tick we do not believe is currently established in Colorado. During the 3 years, we got one tick from each of the 4 represented counties. So we did not see multiple life stages. We did not see multiple ticks. So at this point, we don't think that this tick is established here, but it can easily come into the state, fall off an animal, and potentially become established. That we have seen westward expansion of this. It is pretty prevalent in all of Texas, eastern Oklahoma, and Kansas, and those states have seen it move westward. So that's something that's sort of on our radar. And this particular tick does carry a lot of diseases that we don't necessarily have here or track. And then the last disease I just wanted to briefly mention is Chagas disease. This is a disease that is caused by a parasite that is transmitted by the bug on the slide. And the reservoir species, wood rats can carry, or pack rats can carry the parasite. At this point, we've not definitively established what our reservoir host is, but we do in fact have the parasite, which was a new finding about 1.5 years ago for us. The bugs are called triatomine bugs or kissing bugs. It's a very common disease in Latin American countries. The acute phase is often asymptomatic or may have a very minor skin condition, but a chronic phase can develop, which can affect the heart, the intestines. It can be transmitted from a mother to an unborn child and cause lifelong problems in the child. These are all the kissing bugs that can be found in the United States. So this is where in the country you can see kissing bugs. So kissing bugs are not unexpected. We have them. We expect to see a certain amount of them. And we do have one here in Colorado, and it's the circled one. It's the Triatoma protracti. And then to the far right of the slide, I have crossed out one. The one that I crossed out is the most dangerous bug. That bug is present in more southern states. And it is the one that is most commonly associated with human cases of Chagas disease in Latin America. At the moment, we are not aware of having that bug here in this state, but we do have the protracti. And the difference would be some bug behavior. Not to get too gross, but these bugs carry it in their feces, and feces in an open wound or in the eye is how it enters the body. And our bug actually waits to defecate until after it feeds. So it feeds on the host and then it leaves. So at the moment, we've not seen any human cases associated with our bug here in this state, but we have in fact found the bug, and at least in Mesa County, the bug is carrying the parasite. So it's something that we want our providers to be aware of. We looked, and we have two specific neighborhoods in Mesa County where we know the bug is present and coming into homes and feeding off of people. So we reached out to those communities. We sent postcards. We have people that have been bitten by these bugs. So we have them sort of on chronic testing where they have to be tested annually. And we have created other postcards. So if we become aware of the bug coming into homes and other communities, we are prepared to send out these postcards to the communities to let people know about it, to give them our information, and then to get more bugs in so that we can continue to do testing. The process is we get the bug here. There's a lot of imposters. There's something called an assassin bug that looks a lot like this, that doesn't transmit diseases. So we'll get it in. Our entomologist will identify it to make sure it's a kissing bug. We then send it off for testing, and it's tested for human DNA. If it tests positive for human DNA, we then test it for a parasite. I say we, I don't do it. We send it off for that, tested for the parasite. And then if it does test positive for the parasite, we'll start our process of testing the people that were potentially exposed to it. When I say chronic testing, so that we have individuals that are living in homes that are chronically infested with these, and they have been having trouble getting rid of it. It takes about 8 weeks to become serologically positive. And since they're living with the bugs, how often can you test them? So at the moment, everybody is negative, but we are recommending that they get testing done every year while they are continuing to experience this problem. And I'm happy to take any questions.
Questions for Jennifer? Excuse me. Pardon me, Dr. Pastula?
Thank you for all that. We can work backwards a little bit. The Chagas disease, that's actually really concerning to me. I had no idea that was anywhere close to here. So you were mentioning they live with these bugs. So are these bugs that kind of infest homes, or are they just randomly out in the environment?
Okay, so the particular bugs that we have are associated with pack rats. And what happens is they choose to feed on the pack rat. But you eliminate the pack rats, and then the bugs have nowhere to go, and they are blood feeders. So they are looking for that blood meal, so they will go into the homes to get their blood meal. They can also be found in chicken coops. They will feed off of dogs, and then the dogs will eat the bugs. So we actually suspect we may have some positive dogs at this point because they'll eat the bugs. But the testing is difficult to come by. It's not free. So we've been able to get the people tested, but maybe not necessarily all the dogs tested. But in the particular situation that we are concerned of, there were pack rat nests that were eliminated. But the bugs they didn't do the treatment for the bugs, and now the bugs have kind of dispersed. So it's when you eliminate pack rat nests, you need to eliminate their parasites also.
Yeah. Wow. Yeah. So I'd say encourage just continued surveillance and response to that, because that's really concerning. That if it's newly here, disease that I didn't even think of here. Second question. So I saw the with the ticks, the Dermacentor Andersoni. Do you all do surveillance for Colorado tick fever, which is carried by the Rocky Mountain wood tick?
So it is a reportable condition. So if it were were to be tested and test positive, that would be reportable. We don't actually currently do surveillance. It's something that we hope to start in the future, is possibly actually even doing a serosurvey. But when I say in the future, I'm talking 2 to 3 years down the road. But we're interested in looking at that, and there's really only 2 labs in the country that we're aware of that test for it. So it would be challenging to to do more at this point.
Okay, that's fair. And the third question I have is, with all these numbers of rabies increasing, and especially along the Front Range, one thing that surprised me, that at least I saw in your handout, but that I'm not sure if I missed on the slides, was there certain counties that don't require dog or cat testing or rabies vaccination? I don't think. Oh. Yeah, that one. So meaning if you have a lot of, because humans, if you get a human rabies case, you're probably going to get it either from a bat that comes and bites you, or from your own animals that then contact the skunks, assuming humans don't go and pet skunks, all that often. But I'm just surprised by that, given the large amount of increased rabies cases that counties aren't requiring kind of domestic pets. Is there like a push for like various counties, especially along the Front Range or kind of outside, or kind of more a statewide push to require cats and dogs that are domestic to get vaccinated, given this increase in rabies?
Yes, and so this slide does represent, it's the counties that have ordinances for dog vaccine, and then there's a cat one after this. The red counties are the ones that we definitely know do not. The blue do require it, and then the non-highlighted counties are ones where we don't have good data, which means it's probably no. We're actually we're looking at this right now to try and poll the state and get a better map where it's at least red or blue. And since I've been here, there's not been any changes in any of the counties. So I do encourage it. The local health departments encourage it, but there are still a lot of jurisdictions that don't require it, even in high-risk locations.
And if you want people out with pitchforks, mess with their dogs.
Other questions for Jennifer? Jennifer, just real quickly, kind of anecdotally, I noticed that tularemia is down, and it seems, I think we talked last time, I was asking about foxes, especially in the Front Range. They seemed like their population, at least in my neighborhood, dropped off precipitously a couple of years ago, and the rabbit population has increased. Have you been tracking that at all, and just that interrelationship? And it doesn't look like it's causing any kind of public health issues, but have you seen that?
So we don't really track the density of animal populations. I've definitely heard the reports of the fox die-off and then the rabbit explosions. We did have very large numbers of tularemia in 2014, 15, and 16. After that, we've slowly dropped back to more baseline. In 2018, I believe we had 4 cases of tularemia, which we would consider a normal year. It's still a little higher than if you look back towards the 90s, but 4 cases would probably be what we would expect. It's still out there. It's very persistent in the environment. Probably the real explosion happened in 2014 in terms of the animal population, and it just takes a very long time for the environment to clear it. And it's not a spore-forming bacteria, but it's a lot harder to kill than other forms of bacteria.
Thank you. Other questions? My hound dog's trying to do everything he can about the rabbits, but just can't seem to get on top of it. Anything else?
You get the battle marmots.
Oh, excellent. Well, thank you, Jennifer. That was really awesome and really interesting. Really
Thank you.
Thanks to everybody for sticking around as well. And Tony, thanks for staying with us. Appreciate it. Anything else? I think Deb just had one other little piece of business she wanted to do before we adjourn, but anything else from board members? Okay.
Just real quick, the comment about the vaping and recognition for that work. 2 other bills that are related to that and tobacco review, so I want to make sure you have a heads up. Adding e-cigs to the Clean Indoor Act is out there, as well as a bill that would allow local governments to have more stringent tobacco regulation than the state has without it affecting their tobacco sales tax revenue. So that's a huge shift in practice from prior proposals. So they have removed the poison pill. So just for what it's worth.
Thank you. That's helpful. Anything else? ROL set? Is the snow report still good? Pat? Fantastic. Well, anything else? We'll adjourn so Pat can avoid the snow. All right. Good. We stand adjourned.